You are in practice session.
Good afternoon, Dr. Maya ma'am.
Good afternoon.
Yeah,
Can you
ma'am.
hear me?
Yeah. Your audio is clear. Check your video.
Video, yeah, just a second.
Yeah,
Okay.
clear. Thank you for joining and thank you for coming, ma'am.
No, thank you so much for the invite.
Yeah, it's our pleasure. Happy Women's Day, ma'am.
Thank you so much.
Yes.
Jason sir, please inform us before going live.
Sure, Mr. Gautam.
Yeah.
I've just linked it to the YouTube. Oh, so I'm just checking it.
Okay.
Gautam sir, my camera is not clear.
Not working?
Video is not accepted.
Sir,
Huh?
is it from sir? Is it from here or madam's side?
No, it's from the ma'am's laptop.
No,
Achha.
sir.
Can you please check?
No.
So there's a if you see, ma'am, there's a start video button in the bottom. You'll have to click on it.
I press start my video,
Yeah.
but no response.
Can you log in? Can you again log in, ma'am? Log out and log in.
I will try it.
Sure.
Dr. Tulika ma'am, welcome. Good afternoon.
Good afternoon. Good afternoon. Welcome.
मैम आपका स्वागत है.
Namaste.
जी, जी. Dr. Suman Jain ma'am, namaskar, welcome.
Namaste. Namaste.
Welcome ma'am.
I'll just come back in 5 minutes. Yeah.
Yeah ma'am. Okay. Jason sir, when to start?
Sharp 3 will go live.
Sorry.
3 o'clock will go live.
2
Okay,
minutes.
आप इंडिकेट कर दीजिएगा, रुचिता जी आप फिर स्टार्ट कर दीजिए।
हाँ, सरस्वती जी ज्वाइन नहीं किए अभी, तो
अच्छा,
उनसे भी
बट हम लोग आ जाते हैं 3 को, सरस्वती जी के आते तक हमारा 10 मिनट निकल जाता है, 5 मिनट,
ठीक है, श्योर।
है ना? वी शुड ऑन टाइम आई थिंक, और 2-3 मिनट्स एक्स्ट्रा देख लेंगे।
श्योर।
वेलकम शालू।
गुड आफ्टरनून सर।
हाँ हाँ, आपका वॉइस ठीक है। ओके, और एक जगह स्टैंड करके रखिए आपका डिवाइस, सो दैट मोमेंट नहीं।
ओके सर।
ओके, म्यूट कर दीजिए।
Gautam, I'm taking it live.
स्टार्ट। सर्वे
You can
भवन्तु सुखिनः,
one second, one
सर्वे सन्तु निरामया।
second. Ruchita ji, hold on. We'll wait for 1 more minute. It's live. Let it stream for a minute and then we'll start. So at 3:1 you can start.
So Jason sir, you just say start, that she will start.
Sure. Done.
Thank you.
Start.
सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामया। हैप्पी वुमेन्स डे टू ऑल ब्यूटीफुल लेडीज प्रेजेंट ओवर हियर। आज के कार्यक्रम की शुरुआत करने से पहले हम एक बड़े दुख की बात है कि हमने हमारे एक एग्जीक्यूटिव मेंबर, नास्को के एक एग्जीक्यूटिव मेंबर नोमेश वर्मा को खो दिया है। कल रात उनका देहांत हो गया है। तो बड़े दुख से बताना पड़ रहा है कि हमारे एक परिवार के सदस्यों को हमने खो दिया है। इसी बात पे मैं गौतम सर को बुलाना चाहूंगी, वो नोमेश के बारे में 2 शब्द बताए। ओवर टू यू सर।
धन्यवाद रुचिता जी। आज नेस्को परिवार एक कठिन परिस्थिति से गुजर रहा है। कल ही हमें आकस्मिक निधन की खबर आई हमारे प्यारे लाडले नोमेश कुमार वर्मा जी, जो कि एक सिकल सेल वॉरियर थे और वो रायपुर छत्तीसगढ़ के थे। नोमेश नेस्को मेंबर है। पता नहीं आज इस सेशन को इस तरह से शुरू करना पड़ेगा, ये हमें पता नहीं था। ये एजेंडा में मेरा आना भी नहीं था, लेकिन अनफॉर्चुनेटली नोमेश का चले जाना पूरे नेस्को परिवार के लिए ही नहीं, छत्तीसगढ़ के सभी सिकल सेल वॉरियर्स और उनके जानने वालों के लिए बहुत ही दुखद बात भी है। जब हम कल पिछले 2-3 दिनों से आज के वेबिनार की तैयारी कर रहे थे, सारे नेस्को परिवार के लोग, वहीं कहीं हमें क्या पता कि नोमेश के दिमाग में क्या चल रहा है और ऐसी कौन सी चीज है या ऐसी कौन सी बात है जिसने उसे रेलवे ट्रैक पर लेके गई। कल दोपहर में जैसा कि पता चला है, उसने रेलवे ट्रैक में ट्रेन के सामने अपनी जिंदगी को समाप्त किया। ये बहुत दुखद और चौंका देने वाली घटना है, क्योंकि नुमेश पिछले 4 वर्षों से रोज हमारे टच में था। नुमेश वो व्यक्ति है जो नेस्को के फाउंडेशन डे के पहले दिन से हमारे साथ में थे। उनके साथ हमने नेस्को की नींव रखी, हर हफ्ते चर्चा विमर्श करके हम लोग यहाँ तक आए। नुमेश ने छत्तीसगढ़ में सिकल सेल फाउंडेशन की स्थापना की और छत्तीसगढ़ के सिकल सेल पेशेंट्स के साथ उन्होंने कितने ही अच्छे कार्य किए, जिससे छत्तीसगढ़ के सिकल सेल पेशेंट्स की जिंदगी में बदलाव आया। नुमेश को हमेशा हमने ऐसा पाया कि वो हर किसी पेशेंट्स की, सिकल सेल पेशेंट की मदद करते हुए देखे गए। ना सिर्फ सिकल सेल पेशेंट बल्कि कोविड के समय में वो हर जगह सुविधाएं देने के लिए आगे रहते थे। हमने कई बार उन्हें कहा कि आप अपना भी ध्यान रखें, लेकिन समाज कार्य में वो इतने अग्रसर थे कि उन्होंने ऐसे किसी भी मौके को नहीं छोड़ा। अभी हाल ही में 1 महीना भी नहीं हुआ, हम लोग गोवा में एक साथ पर्पल फिस्ट में हम लोगों ने हिस्सा लिया था, जिसमें नुमेश वर्मा सिकल सेल की तरफ से ब्रांड एम्बेसडर बनाए गए थे गोवा सरकार की तरफ से। नुमेश ऐसा नाम है जो दर्द के साथ देखा गया है। सिकल सेल की पीड़ाओं के साथ उन्होंने जो संघर्ष किया वो हम सभी परिवार के लोग जानते हैं। लेकिन ऐसा क्या था कि नुमेश को अपनी जीवन को समाप्त करना पड़ा, ये हमारे लिए उन्होंने एक प्रश्न छोड़ के गए हैं। आज देश में जब सिकल सेल मिशन लॉन्च हुआ है, तो ये सिकल सेल मिशन सिर्फ स्क्रीनिंग तक तो नहीं है। ये बात आज हमें समझ में आई कि ये मिशन स्क्रीनिंग तक ना होकर के और भी सिकल सेल पेशेंट्स के मुद्दे हैं जिन पर हमें बात भी करनी है और उस पर हमें कुछ ठोस निर्णय भी लेना है। एज ए परिवार के सदस्य हम लोग जानते थे कि नुमेश न सिर्फ पेन क्राइसिस से लड़ रहा था, बल्कि वो अनेक सामाजिक परेशानियों से लड़ रहा था। माँ बचपन में ही छोड़ के चली गई, पिता थोड़ा सा बड़ा हुआ तब दूसरी शादी कर लिए, अकेला वो नानी के यहाँ पलता बड़ा रहा, फिर नानी का भी देहांत पिछले 3-4 वर्षों में हो गया, फिर अकेला हो गया। जॉब नहीं मिलने लगे क्योंकि बार बार क्राइसिस की वजह से भर्ती हो जाता था। रात रात को फोन आते थे कि सर क्राइसिस आया, मैं एम्बुलेंस की रास्ता देख रहा हूँ। वो अकेला एम्बुलेंस में रात को जाया करता था। जब तक एम्बुलेंस आती नहीं थी घर में, तब तक वो दर्द से तड़पता होता था, खुद से इंजेक्शन लगाता था। ऐसा योद्धा हमें समझ में नहीं आया कि इतनी कठिनाई से लड़के आगे आने वाला सिकल सेल योद्धा नुमेश वर्मा कैसे अपने आप को समाप्त कर सकता है। ये सोचने की बात है। आज जो हमारे सारे पैनलिस्ट यहाँ पर है, मेरा उनसे नम्र निवेदन रहेगा कि मेंटल हेल्थ पर भी थोड़ी चर्चा की जाए। थोड़ी चर्चा सिकल सेल के जो पेशेंट जिन्हें रोजगार का बहुत प्रॉब्लम है, उस पर भी थोड़ी चर्चा की जाए। कैसे उनका इंक्लूजन हर सेक्टर में हो, उस पर भी चर्चा की जाए, क्योंकि इस बार वुमेन्स डे का थीम इंस्पायर इंक्लूजन है, तो हमें इन पर भी बात की जाए। ट्रीटमेंट और स्क्रीनिंग के अलावा भी ऐसी बहुत सारी चीजें हैं जो आज नुमेश सिखा गए हमें कि उन पर भी बात होनी चाहिए। तो मेरा आप लोगों से निवेदन रहेगा आज के इस वेबिनार में कि इन तथ्यों पर भी बात किया जाए जो एक सिकल सेल योद्धा को अपनी जीवन लीला खत्म करने पर मजबूर करते हैं। मैं आप सभी लोगों को एक 2 मिनट के मौन के लिए आह्वान करता हूं कि जितने भी पार्टिसिपेंट स्पीकर्स आज यहाँ उपस्थित है और देश भर से जो ऑनलाइन जुड़े हैं, कृपया वे सभी नोमेश के लिए, उनकी आत्मा को शांति के लिए 2 मिनट मौन रखें। शांति, शांति, शांति। मेरे अंत में मैं यही कहना चाहूंगा कि नोमेश का नेस्को के साथ एक अटूट रिश्ता था। नेस्को की शुरुआत से लेके अभी तक वो साथ में थे और अंत में भी जब वो गए, जब ऐसा हादसा हुआ तो पता चला कि उन्होंने नेस्को की ही टी शर्ट पहनी हुई थी और नेस्को के सिंबल से उन्हें पहचाना गया। ऐसे और नोमेश को हमें खोना नहीं है। बस आज के दिन मेरा आप सभी से अनुरोध है कि कुछ उन्हें बचाने के लिए हम आगे आए। धन्यवाद।
थैंक यू गौतम सर। नोमेश हमारे नोमेश के सपोर्ट को नास्को हमेशा याद रखेगा। इस कार्यक्रम को आगे बढ़ाते हुए, the world is full of diamonds and gems, and we are having some of them here today to make this event more beautiful. Good afternoon to all dignitaries, guests, delegates with joy and immense exultations. I feel privileged to extend my warm welcome to all the present here for International Women's Day virtual webinar on women's and sickle cell disease, organized by National Alliance of Sickle Cell Organization, NASCO. To begin with, I am Dr. Ruchita Patel. I am a sickle cell warrior and executive member of NASCO. Currently, I am working as assistant professor in pathology department, Novo Medical College, Silvassa. Today, we are gathered on our digital platform to discuss the topic of women and sickle cell disease. Moving further, we are going to start our day with welcoming address. Here, I am inviting on our digital platform Mrs. Saraswati Chandra ma'am, who is an executive member of NASCO. Ma'am will give us welcome address and context settings. Ma'am, over to you.
Thank you. Good evening and a warm welcome to everyone. Tragedy is always a co-traveler of life, journey of all sickle cell patients. First of all, it is so sad to express my grief and deep condolences on the demise of our fellow warrior, dear Nomesh Verma, executive member of NASCO, who passed away today. Today, on this special occasion of the International Women's Day, let us take a moment to honor the unsung heroes among us. All the women who dedicate their lives for the betterment of our sickle cell community. Words cannot describe the courage and confidence that women with sickle cell anemia receive from these efforts, which are often done without seeking any recognition. Patients, apart from the unbearable pain, face a social stigma that can tire the mind also. In case of women, this can be seen in every aspect of her life, starting from early childhood throughout her adulthood. The challenges mount like a mountain. Even adequate nutritious food is a struggle for a girl child. Paired with the complications of disease, make life hard for her. Thanks to various governmental and non-governmental efforts, this gap is closing. School-going students lose too many classes because of these complications of this disease. Improper framework in our education system to also make life hard for these children even at such an early age. Adulthood also brings its set of challenges both physically and mentally. Pressure from the society and social exclusion is also a huge hurdle for us. I take this opportunity to convey the love and greetings of my parent organization, which is a patients-only organization of sickle cell community. We are struggling for the last 25 years, raising the issues of the sickle cell patients who are not only the victims of this disease, and also all kind of negligence from the society, establishment, and even that of the family itself. Apart from all these harsh realities, we are able to cross these hardships. We are proud that we have helped each other to face these hardships and overcome them. A special thanks to Government of India for announcing the National Sickle Cell Anemia Elimination Mission and for allocating funds for it in the budget. The mission crossed 1 crore screening in January of this year, and we hope that it will be one of many such milestones to come. Today's program will be conducted in 2 parts. How care is delivered with equity and its aspects will be discussed in the first panel discussion, which is moderated by Dr. Tulika. Though sickle cell anemia is often perceived from a medical standpoint, the social and the psychological factors are neglected to a great extent. These challenges and the ways to tackle this will be discussed in the second panel discussion, which is moderated by Dr. Deepti Jain. On behalf of NASCO, I take this opportunity to welcome Dr. Manisha Madgarkar, ICMR NIH. Srimati Vinita Srivastava, Ma'am, Ministry of Tribal Affairs. Ms. Bipa Tinga, Global Alliance of Sickle Cell Disease Organization. Dr. Maya Sharma, Novo Nordisk. Regina Hartfield, Sickle Cell Disease Association of America. Dr. S.D. Talia, Indian Society of Immunohematology. Professor Julie Makhani, Sickle Cell Foundation of Tanzania. Srimati R. Jaya, Ministry of Tribal Affairs, and the expert panelists, session moderators, and all those who have joined us. In this special day, I urge all women in the sickle cell community to extend our hands to each other and tackle our hurdles together. Thank you all.
Thank you, ma'am, for your welcoming address. Now, moving further on our journey, I would like to invite Dr. Manisha Madgaikar, ma'am, Ma'am is Director, ICMR, NIIH. Ma'am will brief us on ICMR, NIIH initiative towards prevention of sickle cell disease. Welcome, ma'am. Over to you, ma'am.
Thank you so much. At the outset, sincere thanks to Gautamji and NASCO for organizing this workshop and inviting me to be part of this workshop. I'm really deeply saddened by the news that you have shared, and it really highlights the importance of psychosocial support that we need for patients with sickle cell disease. So it's NIIH, ICMR, NIIH has been working in the area of sickle cell disease in more than 30 years now, beginning with large multicentric studies that ICMR NIIH has done for understanding the prevalence of sickle cell disease in general population as well as in different tribal populations across India, creating a map, and now we have created an atlas collating all the references that we have from India to accurately map the sickle cell disease prevalence. After prevalence, then comes awareness and antenatal screening. So again, Dr. Roshan Kola, Malay Mukherjee, along with many people who are here with us on expert panelist, Dr. Dipchi Jain, Madam, Dr. Italia, they have done extensive work in community awareness as well as initiating newborn screening program, one of the first newborn screening programs in India, in association with Dr. Dipti Jain Madam and Dr. Italia, that we had demonstrated, and now we are having a multicentric newborn screening in 7 centers across 6 states in India, high prevalence states, and comprehensive care that we are giving. And this is one of the important programs which will not only help us in understanding the prevalence of these disease in different districts, but also understand how these newborns from different areas, whether there are any regional variations in terms of clinical manifestation, the age at which they manifest, how many of them go have a severe disease, whether any genetic modifiers which are different from different regions, which help in modifying the disease severity. So currently we have screened more than 60,000 newborns across the country and identified nearly 500 newborns in these centers which are receiving in comprehensive care. Apart from newborn screening, prenatal diagnosis, the NIH has been one of the first institutes in India to initiate or establish newborn prenatal diagnosis for affected families for hemoglobinopathies, including sickle cell anemia. We have performed till date more than 6,000 prenatal diagnoses, and more than 2,000 of them are in sickle cell disease. And we have also, under a mission mode program, created trained 7 centers across India for establishing prenatal diagnosis. Then NIH, realizing the importance of this problem in the central India, especially around the region of Chandrapur, a satellite center was established to benefit the local people. And there also we have initiated activities like population screening, population awareness program, community screening, antenatal screening, and providing them prenatal diagnosis. So this satellite center was established in 2015. And looking at the work and output of this center, a permanent center, or now, in fact, as a big institute has been established in Chandrapur, which is Center for Research, Management and Control of Hemoglobinopathies. And currently, this institute is predominantly working in the area of sickle cell disease. Now, we have also initiated a large multicentric study, first randomized clinical trial, which to compare low dose hydroxyurea versus 20 milligram per kg hydroxyurea And again, the results of this important study will help us whether we initiate with 10 milligram, whether 10 low dose is equally effective or 20 milligram is required. What is the side effect profile when we compare 10 milligram versus 20 milligram? And which are the cases where which doses can be given. We are also looking at effect of genetic modifier and whether any one of them will help us decide whether we should start with 10 milligram or 20 milligram. Apart from that, the center at CRMCH has, because it is recently inaugurated, it has recently completed its first birthday. And we have initiated important studies, which another 2-3 years will give us good data, understanding the spectrum of organ damage in these patients, understanding the genetic effect of genetic modifiers on the clinical severity, understanding the importance of malnutrition and micronutrient deficiency, including iron deficiency, and management of these, and which will help in patients with sickle cell disease. Barriers of therapy for hydroxyurea. So understanding why still majority of the patients are not on optimum doses of hydroxyurea. What are the different causes? So this study also, we have now completed the data collection, and the results will help us in addressing the issues, because one of the most important treatment is hydroxyurea in these patients. And apart from that, NIH and CRMCH, that is the center in Chandrapur, both of us are also involved in validating the different kits, that point of care kits or sickle cell related diagnostic kits. And more than 7 kits we have validated, and really happy to share that many of these kits are good quality, indigenous, and many of them are very cheap compared to the outside kits. So we hope that if the quality of these kits is maintained by the Indian companies, we don't have to buy the expensive ones from outside. And I think that is overall in 5 minutes what I can share about the NIH work. But anytime if you need any other additional information, I'll be happy to share. Thank you so much once again.
Thank you, ma'am. We are really appreciate and grateful for the ICMR taking initiative towards prevention of sickle cell disease. Thank you so much, ma'am. Now moving further, I feel honored to have with us Srimati Vinita Srivastava, ma'am. Ma'am is advisor of Ministry of Tribal Affairs of Government of India. Ma'am will address us equitable comprehensive care for sickle cell disease, Ministry of Tribal Affairs, Government of India. Welcome, ma'am.
Thank you so much. It's a pleasure to be here, and all the dignitaries who have joined, and all the patients, Dongreji, and everybody who has joined this webinar. I really have a respect for them, because the concern is those who are working for sickle cell disease is a big thing. And when we call them warriors, it's very important, because why we call them warriors is somebody who is going to fight against the disease. That's very important. And learning from you guys is a real blessing to me, because I have learned from the patients, and much of the problems which I could understand from the patient, it was patient themselves who make me learn that what exactly is the problems. Concerning to the, basically, if we talk about Ministry of Tribal Affairs, has really taken some good efforts in 2016 when we started with the screening with DBT. And that time I was in Ministry of Health, and we came up with certain, this is a mission which came up is with the evidence, because it came with the evidence, and we can call it as an evidence-based mission. So this was a big learning and startup. Then we started, and after that, gradually, Ministry of Health also took up initiatives. 2016, the hemoglobinopathies guidelines came in, and finally we started with little bit of screening. I mean, screening in the state could understand what exactly is the blood disorders, because till that time there was no if you can see these state PIPs, there was no blood disorders, sometimes no FMR codes for blood disorders or for blood. But finally, it came in, the blood services and blood disorders came in the ministry as an intervention from NHM side. It was a great initiative at that time because it was basically a learning stage for all of us. And we can understand, and then these patient groups and everybody came into picture. They started telling about their problems, what exactly the problem said. And some of my mentors are here, like Dr. Deepthi Jain, Tulika Seth, everybody was there. Those who let me know, yes, these are the problems one has the patient face, and we have to develop these guidelines according to their issues. So don't sit on this side of the table, rather sit on the other side of the table and understand what are their issues. So it was a good learning, and I'm thankful too, because everybody, Dr. Italia and everybody might be here. And so all these things came in learning, and we came up with a sickle cell mission, which was launched in 2023 itself on 1st July. And we came up with these awareness modules, counseling modules, then the management modules, everything came in. And now we also targeted to have the identified trainers in the so the training was that these trainers were identified, and we want to start with the training in certain areas, and some of the areas like we did a good training in Andhra Pradesh also. Recently, we did it in Bhopal. I mean, it's all a learning process. So, but every time when we do some training, something or other comes in, yes, this has to be important. So all these things are basically a learning process. I cannot say this is I mean, though much of this screening has been done, but now the concern is the people who are screened, how to manage them. And women, on this day, I should say that they are the most vulnerable people, because suffering of them has to be understood. A woman having a sickle cell child, or women herself having a sickle cell and giving a birth to a child, both are very important. And this we are lacking on this part. इस पे कुछ guidelines होनी चाहिए, which is not there. And I personally feel, and from the ministry side also will take it up, that Ministry of Health comes up with the guidelines which is basically meant for the women living with sickle cell disease and those who are going to give birth. So these are very important, and because they basically have so many problems. It's not one thing which they suffer. There are certain other things which also comes in. The comorbidities are there. So all these things has to be kept in mind to come up with these certain guidelines. Yes, we are also trying to get some center of competence, which is still in pipeline. But definitely one day will be a day when we will have good center of excellence, where we have a good referral systems, where people will talk about, yes, we have a management systems in place. Yet it has to be done, because it's not an easy job. And states also has to take up a initiative, because health being a state subject, states has to take initiative to come up and with their own funds or CSR funds or from the funds from any ministry which comes in. Health is like any ministry can participate and give it to it. Now I have seen some wherein agriculture also is coming and RD also is coming. It's a great thing. But the conversion model will give us a model where everything will be in place. So with these lines, I really respect people who have joined us, who has given a new path, especially the patients group who has given us a new path to understand what are the issues and how we have to cope up with. So thank you so much and I am very thankful to everybody, because I am a part of this. Again, a good learning to me to understand how exactly we have to make the ways where the patients get enough management services to keep up with their lives, and their survival rate is better, and at least they are having a normal life as other people live. Thank you so much.
Thank you so much, ma'am, for giving us overview on comprehensive care of sickle cell disease. Thank you so much, ma'am, for giving your valuable time and connecting with us. We are so grateful to you, ma'am.
Thank you so much.
Now, moving forward, we are having Miss Biba Tinga, ma'am. Ma'am is President and CEO of Global Alliance of Sickle Cell Disease Organization, GASCDO. Ma'am will brief us on GASCDO commitment to the global sickle cell disease community. Due to difference of time zone, ma'am will not connected, but she has sent a video. Please play the video.
Hello, everyone. Before I begin, I would like to thank NASCO for inviting GASCDO to speak to you all on this International Women's Day. We also want to recognize NASCO for all the work it has done and continues to do within the South Asian sickle cell disease community. Being a woman living with sickle cell disease or caring for someone with sickle cell disease has a partner, a spouse, or a healthcare provider. The path ahead is not an easy one. We here at GASCDO would like you to know we see you and all the work you do, whether you are recognized for it or not. Today, I would like to address an issue many women have experienced, but not sure how to verbalize. It is the experience of broken dreams. I know the numerous struggles you all face when attempting to access care, when advocating for your loved one, when you raise your voices to bring attention to your inmate needs, or of course, when addressing the chronic pain that is a major part of living with sickle cell disease. For a woman to stand in the advocacy field, she must transcend so many obstacles linked to gender inequity, which might come in many forms, including access to higher education, access to relevant information, support from family members, support and stigma from the community at large, barriers to employment, and sometimes just being heard in this male-dominated world. We are expected to speak up, but politely. For many women, this leads to many broken dreams. Fighting like I did to complete my education, create a career path I will be proud of, all while ensuring my child with sickle cell disease receive the absolute best care possible while dealing with being a young mom and carrying the sickle cell trait was not easy, with the thought of giving up always in the back of my mind. These were some of the many strengths I brought to GASCDO when elected to become the current CEO and president, and what I believe can be gained from women in leadership roles. I want you all to know I see you. GASCDO hears you and wants you to know that women lead the majority of the global sickle cell advocacy work and are at the forefront of improving care for all globally. While we all continue to face our individual challenges due to geography, culture, politics, economics, etc., we want you to keep going. You are not alone, even sometimes you might feel you are alone. We encourage you all to reach out to your local organization like NASCO in India, ACDA in America, or ACDAC in Canada. To fight sickle cell, no country or region should act alone. Stay connected to GASCDO as we engage countries, policymakers, industry partners, work with one voice. In this regard, this is why in our strategic plan at GASCDO, we have committed to creating, implementing, and sharing the result of the first ever global survey to assess the community with specific questions tailored to you, the sickle cell female advocates. Coupled with our commitment to help each member organization grow through capacity building, thereby ensuring that any assistance you might need will be there where you need it in your community. And finally, we couldn't be more excited to announce the first ever global conference on sickle cell disease, which will be taking place in November in Oman, where we look forward to seeing all the strong advocates, strong leaders, caregivers, and warriors. Our words today are those of encouragement and support. Keep fighting.
Thank you. Thank you for playing the video, and thank you. We are so grateful for having Biba Tinga, and NASCO is so grateful to connected with Global Alliance of Sickle Cell Disease organization, and we are very glad that we are part of Global Alliance of Sickle Cell Disease organization. Now I'm privileged to invite Dr. Maya Sharma, ma'am. Ma'am is Vice President, CMR, Novo Nordisk.
So thank you.
Ma'am, please brief us on commitment towards sickle cell disease. Welcome, ma'am. Over to you, ma'am.
Thank you so much. Please help me understand if you're able to share my to see my screen.
Yes, sir. Yes.
Okay, great. So I would quickly talk about how Novo Nordisk as an organization, which is primarily known for diabetes since the last 100 years, is also venturing into rare diseases. So besides the mass disease, which is diabetes, we realize that, a lot of attention is required, a lot of purpose is required at these rare diseases, because we want to defeat rare blood and endocrine disorders. And we can only do so by pioneering scientific breakthroughs, expanding access to our medications, and working to prevent and ultimately, if possible, even cure diseases. If we see our presence in the world, we are present in 100 countries with affiliates in 80. And we are working on various of these diseases, such as hemophilia, growth hormone, sickle cell, thrombocythemia, as well as primary hydroxyurea. And if I have to focus now on hemoglobinopathies, something which all of us are so well versed with, but just to reiterate the purpose, to reiterate the resolve, I would like to highlight that when we talk about sickle cell disease in India, then we have the second highest incidence with more than 42,000 annual births after Nigeria. And 20% of these children with sickle cell disease die by the age of 2 years in India. And though sickle cell has been gaining a lot of attention and momentum as a global public health issue starting from 1973, when the US first recognized and started the Sickle Cell Anemia Control Act, followed by the massive screening program in 1993, and the Sickle Cell Treatment Act in 2003. It was only in 2008 that globally it was United Nations which recognized that sickle cell disease is a public health problem. And then later in 2014, US FDA said that SCD patient-focused meetings would be done, and there will be development of new SCD drugs, which will become a top priority. If I come closer to India, then it was recently in 2016 when the National Health Mission guidelines on hemoglobinopathies in India came up. And then just last year in 2023, the National Guidelines on Management and Control of Sickle Cell Disease and the National Sickle Cell Anemia Elimination Mission, which actually gave directions and purpose to a lot of us. But let me tell you, with all this, the last approved drug which has been used worldwide was way back in 1998, which is hydroxyurea. It is then that US FDA had approved hydroxyurea. And it has been 25 years, and though there have been clinical trials, most of them have failed with newer molecules. Even when there have been newer molecules, they have been approved in a few countries. So after hydroxyurea, which is still considered toxic by many, we haven't seen any safe drug options. And we realize that there are still a lot unmet needs, whether we talk about patients and caregivers side, which is regarding the desire of these patients to lead a normal life free from pain, fatigue, and social stigma, or the ability to offload families and caretakers from sickle cell disease, or whether it is about disease management that is tailored or customized to each patient's need. There is also lack of adequate and clear awareness on both the disease part as well as its management. And not just that, when we even talk about the disease burden, we see that epidemiologically, diversity across the globe is there, but there are still poor reporting systems. Overall, there is sparsity or lack of sickle cell disease specialist professionals and centers. And when we reach out, even to mass centers and ask, they are clueless about, how it has to be managed or even diagnosed. And that leads to delayed diagnosis. Also, there is lack of screening. The access to effective and well-tolerated treatment that addresses the disease complications throughout life are also a challenge. And when we look into what are the 4 pillars of sickle cell disease management, they are indicative of the supportive management to maintain the general good health. Then the symptomatic one, most of us are trying to use that as well as preventive ones to alleviate the symptoms of pain, anemia, and infections, which are the painkillers, blood transfusions, antibiotics, L-glutamine, crenalizumab, and treatment like hydroxyurea, hydroxycarbamide, or voxelotor. In terms of curative, as of now, it is only hematopoietic stem cell transplantation, which is available, but it's an option only in a few patients. And that is why we at Novo Nordisk, we are having that ambition to build a portfolio in sickle cell or in hemoglobinopathies, which will address the individual patient needs. And a couple of molecules which are already in our pipeline are NDEC and etavopivat, which we are trying to test both in sickle cell disease and beta thalassemia, but also to come up with newer therapies which will provide the next generation symptoms relief, which will be the disease modifier and may even provide the curative treatment. And if I have to showcase you the pipeline and what is available is I would say the molecules with NDEC and etavopivat and the trials by the names of ASCENT, the transcranial Doppler study, Hibiscus 1, which is a phase 2 trials, Hibiscus 2, which is a phase 3 trial, and Gladiolus trials 2 and 3. And very proudly, I can say that though, we are talking about rare diseases like sickle cell disease and beta thalassemia, and when we talk about the Indian representation in clinical trials, it has been abysmal. Overall, we contribute to just 4% of global clinical trials. But I would say, thankfully, here at Novo Nordisk and from Novo Nordisk India, the clinical team is trying to pursue more and more of these trials so that there can be a good representation of Indian patients. And we can say that these drugs are customized even for Indian patients. So we are contributing more numbers to a tune of 25 to 40% in these clinical trials. And in the last, I would like to say that with all this vision and mission and the trials that we are trying to participate to bring the drugs with better patient outcomes, I would say that we all have dreams. But in order to make dreams come into reality, it takes an awful lot of determination, dedication, self-discipline, and effort. I know it's a tough journey. It's a challenging journey. Just, in the beginning, we heard about Nomesh Verma's, sadful demise. I mean, it was so unfortunate that a warrior like him, who was giving hopes to many, himself lost his life. Let us not lose any more patients. Let us not lose any more warriors. Let us come together, all of us, from both the sides, join our hands together, understand that, yes, it is going to be a tough journey, but together we can definitely make it. Thank you so much.
Thank you, ma'am. We really appreciate your enlightening overview, how Novo Nordisk on commitment towards sickle cell disease and treatment point of view, sickle cell disease. Thank you so much, ma'am. Now, moving further, I would like to introduce Regina Hartfeld, ma'am. Ma'am is President and CEO of Sickle Cell Disease Association of America. Ma'am will introduce us on international perspective on sickle cell disease care. Due to, again, differentiation of time zone, ma'am will not connect it virtually, but ma'am is sending us a video. Kindly play the video.
Greetings. I am Regina Hartfield, and I am the President and CEO of the Sickle Cell Disease Association of America. I am honored to have been asked to provide a video for NASCO's International Women's Day program on women and sickle cell disease. And I thank Mr. Gautam Dongre for this esteemed invitation. I would like to begin by telling you a bit about the Sickle Cell Disease Association of America. also known as SCDAA. We are the national voice for sickle cell disease and represent a membership of 56 community-based organizations spanning 30 states across the country and collectively serving 500,000 people living with or impacted by sickle cell disease. Our community-based member organizations are on the ground every day, working with families, working with individuals, working with women and their children to make a better life and to increase the quality of life and access to care for sickle cell disease. Our mission is to advocate for people affected by sickle cell conditions and empower community-based organizations to maximize quality of life and raise public consciousness while achieving the search for a universal cure. And we execute on our mission in 6 broad areas of emphasis: research, public and professional health, advocacy and legislation, patient services, community services, and support to global organizations and practitioners. And this is the particular area that brings me here to speak with you today. SCDAA is home to the Medical and Research Advisory Committee, also known as MARIC, which is a group of esteemed medical and research professionals whose expertise is sickle cell. These members are representing countries across the world, from India, Ghana, Italy, Canada, and more. SCDAA is also on the board of the Global Alliance of Sickle Cell Disease Organizations, also known as GASCDO. These affiliations give us insight into the role and responsibilities of women living with and or caring for someone living with sickle cell disease. It also gives us insight into the challenges that you face every day. As a woman, we carry the load of life on our shoulders. We are the wives, mothers, sisters, grandmothers, and aunts, and more of the world. Our skills, knowledge, wisdom, courage, and perseverance are key to not only the survival of our families, but to the communities in which we live and work. And we do not take those responsibilities lightly. Sickle cell disease impacts the quality of life and a woman's ability to be fully present for all of the above and more. At every stage of life, from birth through puberty to young adulthood to full adulthood to senior age and above, the disease can rob you of precious time. But historically, this is an exciting time for sickle cell disease. From the many disease-modifying treatments and therapies, and now gene therapy, there has never been more options for care or more hope for a cure. But we also know that in many countries, the availability and access to these therapies and treatments are difficult to access or may not exist at all. These may not be options for you. Basic treatments such as hydroxyurea may be the only option available to women living with this disease. And the cost for medical care is always an issue. Securing time away from work to seek treatment is also not easy, or to care for someone with sickle cell disease is also not easy. These and many, many other disparities are the outcomes of classism, racism, economic and political machinations, and are hurdles that far too often seem insurmountable. But we want women living with sickle cell disease in this world to know that you are not alone. Global and local sickle cell organizations such as SCDAA are fighting for equity and access to quality and compassionate care for you and your loved ones. We're fighting every day to ensure you have access to as many treatment options as possible and that they are available on a regular basis so your care can be continuous. On this International Women's Day, know that on a local, regional, and/or national level, the voices of women living with or caring for those living with sickle cell disease, those voices are being raised. They're being heard and they're being responded to. We won't give up because you don't give up. I thank you for your time. I thank you for your spirit and determination, and I thank you for inspiring us to do all we can for the global community of women living with this disease. Together, we can work in unity toward progress. Thank you.
Thank you for playing the video, and thank you, Regina Hartfield, for connecting with us and giving us an informative message regarding international perspective on sickle cell disease care. Now, moving further, I am profusely elated to take an opportunity to introduce our honored guest of the day, Dr. Yazdi Italia, sir. Sir is renowned microbiologist who is pioneered the development of India's inaugural sickle cell anemia control program, has been awarded the Padma Shri Award on the event of Republic Day of 2024. Sir is a chairperson, West Zone, India, Indian Society of Immunohematology. वेलकम सर। आज नास्को परिवार आपका शब्द सुमन से फेलिसिटेशन करना चाहता है। वी आर so grateful to be with you, sir. Welcome, sir.
Thank you very much for all your kind words. We are working since long on sickle cell anemia, and we are so happy that now it is a national program, and our Prime Minister has also launched a mission to eliminate the birth of sickle cell disease child by 2047. So we are now progressing, and really it is a very happy moment for all of us. Anyway, good afternoon, everyone, and happy International Women's Day to all the women attending this webinar. First of all, I would like to express my appreciation to all the women I'm associated with, both at home and at the workplace. I have always enjoyed working with them and have no hesitation in giving them the respect and appreciation they deserve. I also express my confidence and trust in their abilities when the need arises, and they have contributed significantly to my success, and I am grateful for their help. So when it comes to sickle cell anemia, it is important to take extra care of women, especially during pregnancy, and institutional delivery is a must for them. It is recommended, I would recommend, to have both an obstetrician and physician present during their pregnancy, and we must assure that it will be done in near future. We should prioritize screening of all pregnant patients for sickle cell disease and strive towards achieving a zero birth rate of sickle cell disease as early as possible. Investigation for hemoglobinopathy should be included in Janani Sishu Suraksha Yojana, just like blood group and hemoglobin and other HIV and other factors. So it is crucial to prevent marriages between two people who carry the sickle cell gene. And if such marriage occurs, it is essential to provide ethical counseling for prenatal diagnosis. Counseling is must, and it should be 100% voluntary. And medical termination of pregnancy if the fetus is homozygous for sickle cell disease or double heterozygous. So in case of two successive MTP due to homozygous for sickle cell disease or double heterozygous fetus, the government should provide free assisted pregnancy. Nowadays, assisted pregnancy is available in almost every metropolitan city, or otherwise AIMS should take up this task, as there are 24 AIMS in different parts of India, and they should provide free services for this purpose. Another thing, that in one of our ICMR multicentric project amongst different tribal groups, we have found 66% iron deficiency in sickle cell disease patients. So based on this evidence, I would recommend the government to provide iron fortified rice for free public distribution in ration, which our government is going to provide for next 5 years. It has been announced. So all these type of things are necessary for the benefit of the good health of the women. And I hope that with the present ongoing project on sickle cell, program on sickle cell, they are going to be benefited. They are lucky to have a very dynamic Prime Minister who is taking a lot of interest in our program, and this political will definitely help in improving the life of our sickle cell disease patients in general. Thank you very much. Thank you.
Thank you so much, sir. NASCO is congratulate you to all the success and opportunity and a Padma Shri Award. Thank you, sir. Thank you for coming and connecting with us and giving us your valuable time. Now, looking forward, we are having a Professor Julie Makani. Ma'am is Muhas, Tanzania, Sickle Cell in Africa, Imperial, UK. Ma'am is briefers on sickle cell disease in Africa, a perspective from Tanzania. Again, due to difference in time zone, we will play a video of Miss Julie Makani.
Thank you very much for inviting me to say a few words on International Women's Day. Thank you for the organizers of NASCO India for this wonderful event. It's an honor to share a few thoughts. So I will share a few thoughts from 5 different perspectives. The first one is as a doctor, I think it's very, very critical for doctors, especially women who are doctors, to be part and parcel of the healthcare providers who provide service for patients with sickle cell disease, who provide healthcare. And when you look at the healthcare providers, you have doctors, but you also have nurses, community health workers, as well as all cadres of healthcare providers. And I think it's valuable to appreciate and to recognize the work that healthcare providers have. As a medical doctor, I've been looking after patients with sickle cell disease for more than 20 years. And one of the things that I found out that as a doctor, I may have half an hour, 15 minutes, 1 hour to speak to a patient or a family with sickle cell disease, but other healthcare providers, whether it's nurses, have a lot more time with patients, and therefore the education and the care that by healthcare providers needs to be recognizing that. I think the second aspect is so I'm a medical doctor and I'm also a scientist, and I feel that it's really, really critical to have women involved in science, involved in research at every stage, whether you're a basic scientist, whether you're a laboratory scientist, whether you're a clinical scientist, whether you work in social science, being able to understand why the behaviors of people, the behaviors of patients, the behavior of doctors or healthcare providers, the behavior of policymakers. How can we understand behavior so that we can influence and increase the care that we want to provide to patients with sickle cell disease? We do not have enough women actively participating, actively leading scientific programs. So I think it's important to kind of recognize the women who are doing that and also encourage women to participate. Thank you very much. Sickle cell disease was thinking about pursuing a career in in science or thinking about having children or thinking about pursuing a career in another area. As a teacher or education, you're constantly providing education. And I think, again, it's easier, relatively easier for education to be provided and to encourage people to pursue a career when they see that there's similarities. So if I am talking to a group of young girls or to a group of early career scientists, I would hope that they would look at where my journey, all the failures, all the successes, all the lessons that I learned during this path, and they're able to say, if she can do it, I can do it as well. Or how did she do it, so that I can learn from her and avoid the mistakes that we make, and also learn from the successes that we have. So those are the three areas: as in health, in research, and in education. So finally, it's really to talk about this from the perspective of being a woman, and also on a personal note as an advocate. I have been an advocate for sickle cell disease for many years, mainly because family members have sickle cell disease or have sickle cell traits. So it's been part and parcel of my life from when I was growing up. I think have many striking experiences. One of the most striking memories that I have with sickle cell disease is when my cousin, called Dr. Richard, who 3 of them were born with sickle cell disease, and he was diagnosed when he was a young adult. And so it was really, and he had a severe painful episode in our house when this happened. So I still remember watching him experiencing this excruciating pain, and then going through the process with my mother of having him diagnosed with sickle cell disease, and just realizing the impact that the disease has on individuals, on families, and on the community. So I would really like to thank and appreciate the people who continue to work in sickle cell disease. I would really like to pay tribute and remember the people who have passed away from sickle cell disease, and those who are living with sickle cell disease, really to pay tribute to your lives and to the work that you're doing in raising awareness about sickle cell disease and looking to see how we can find scientific solutions and healthcare solutions to alleviate the suffering from sickle cell disease and find a cure for the disease. Thank you very much for listening to me.
Thank you. Thank you for playing the video. Thank you, Professor Julie Makani, for giving us a perspective from Tanzania. I'm really glad that I'm connecting with globally, and sickle cell disease perspective. Today we are connect with each and every corner of the globe, and we are connecting the perspective and knowing the perspective of what sickle cell disease is and how a sickle disease person is suffer from. We are really grateful to connecting with you. Thank you so much, everyone. Now, moving further, uh, I feel honored to have with us the Honorable Chief Guest, Srimati R. Jaya Ma'am. Ma'am is Additional Secretary, Ministry of Tribal Affairs, Government of India. Ma'am will brief us on keynote address, Women and Sickle Cell Disease on International Women's Day. Welcome, ma'am.
Thank you so much, Ruchika. I hope I am audible to everyone.
Yes, ma'am. Yes.
First of all, I would like to thank NASCO for having thought of me on this day, and I'm extremely privileged to be a part of this discussion today, to be a part of both Women's Day celebration and this extremely important discussion that we are having on women's health vis-a-vis sickle cell disease. First of all, I would like to start with condolences to Numesh, whom I unfortunately have not had the privilege of meeting, but whose life has been described by Mr. Dongre in such great detail, and who I understand, I know, has contributed so much to spreading awareness about sickle cell disease and how to manage it, being himself a sickle cell warrior. My deepest condolences to his family, and I join all of us in wishing that such further incidents don't happen. And today's efforts, I hope, would be a small step, rather a big step in that direction. So my condolences again. And I see before me a veritable who is who of the sickle cell world. Dr. Italia is here, Dr. Deepti Jain is here, Dr. Tulika is here, Gautam Dongre himself is here. We have our international sickle cell warriors and sickle cell activists here. It's forgive me if I'm not taking everybody's name. It's really, I'm humbled by this gathering that's here. And I take this opportunity to wish every one of us, men and women, rather I must say women and more specifically men, a happy Women's Day. And I will also use this opportunity to not only talk about sickle cell disease, which all of you are much more versed in than I can ever hope to be, but also to talk about perhaps how as women we experience disease and how as women perhaps some of us are many of us are experiencing sickle cell disease. One of the things that had come out in the earlier discussions was we need more women in the research aspect of sickle cell disease. I second that. And I would like to kind of put in perspective what we mean when we talk about women's health on Women's Day. We all know that throughout the world, there has been this entire nature versus nurture debate, and women have been seen as the more nurturing kind of the gender, as people who are more caregivers, who are also to a large extent thrust into those kind of parenting, caregiving, and nurturing roles that are vital but often unrecognized in society. And having said that, one of the things that come about is that women are prone to neglect their own health. I repeat, women are prone to neglect their own health. And when someone is affected with sickle cell disease, this can be extremely, extremely dangerous, especially in the very early days, in some cases before detection. There is a possibility that certain pains, certain symptoms are dismissed as being normal, and the early diagnosis may not take place. And even after diagnosis, there could be a tendency to delay treatment, to delay management. It's not a curable disease, no doubt, but treatment for the crisis that has arisen. So women find themselves financially the worse off, physically the worse off, nutritionally the worse off. In terms of caregiving, they have to play the primary role of caregiver, of parenting, and therefore their health more or less in almost all communities, in almost all circumstances, comes last. And when someone is chronically ill, it becomes so much more difficult to find a permanent caregiver unless and until that caregiver has a very strong attachment to the woman in question. So all these lead to a more disastrous effect, more distressing effect on women when they suffer from chronic diseases, and especially when they suffer from diseases like sickle cell. And therefore, what I will request all women and all our esteemed gathering here today is to also impress upon women when we have women patients come in, when we are the suffering women, when they are the women who are the caregivers, be it professional caregivers or primary caregivers. If we could simply impress upon women that they need to take care of themselves first. We all know that the airlines always announce that in case of a crisis, if oxygen drops, first have your mask on, and then even if it is your own child, even if the child is a helpless infant, you must first have your mask on and then have the mask on for the child. It's a very simple logic that if you don't take care of yourself, you will no longer be able to take care of anyone else whom you need to take care of. So the logic is very simple, but often emotions don't follow logic. And therefore, the woman is likely to say, okay, I'll first look after a child who is ill while I neglect my own knee pain or my own joint pain. And then the pain worsens and she needs to probably go into the emergency. So this is something I thought I would flag off today. And the way in which perhaps we can also encourage women and men to also take up caregiving role on this Women's Day is to encourage volunteerism. We have in India, we have this entire self-help group ecosystem. In our rural areas, self-help groups have been game changers to an extent unimaginable. Whether it is in rural development, whether it is in agriculture, whether it is in textiles, whether it is in tribal areas, this self-help group concept has led to women gradually. It's been a decades old, many decades old movement that's on in the country. I think we started sometime in the late 80s, and since then, since the 1980s, in the last 30, 40 years, we have seen the number of self-help groups grow exponentially. We have seen the way in which they have led to empowerment of women, both financially and socially. And I would suggest that we need to tap upon this group of women who have braved many odds to also look into volunteerism towards the sickle cell cause. After all, as sickle cell diseased persons live either in urban areas or in rural areas, more likely in rural areas. If they are in rural areas, then how do we spread awareness about the disease? How do we handhold, mentor, and kind of add a caregiving element that is in addition to the caregiving that's already there for women in these villages? A Sakhi kind of a concept has been going around. We have the rural development Sakhi, we have the agriculture Sakhi, Krishi Sakhi, we have n number of Sakhis. Maybe a Sakhi concept is what we want, and women would probably understand women better. And then there are, of course, there are issues that are peculiar to women, whether it is menstrual hygiene, whether it is access to women products that are health related, whether it is an emphasis on women related, health related focus in research and in treatment. People are likely to take a man's pains more seriously than a woman's pain. That's a part of the social milieu that we are all a part of. But there is a need for all of us as professionals to de-emphasize that kind of a discrimination, a quiet, silent, invisible discrimination, but a discrimination nonetheless that's happening across the globe. Also, financially, there is perhaps a need for volunteerism. There is perhaps a need for many states have their own sickle cell disease programs running where it's now most of them are non-discriminatory. They have the same kind of financial empowerment of the sickle cell disease, irrespective of gender. Nonetheless, maybe there is a cause to look at how that money is spent, whether it is actually going in for the care of the people, whether the nutritious food that is required is there. So there is a lot of on-ground activity, on-ground interventions that need to be done. And here, as I said, volunteerism is probably the answer. Also looking into more data. Our ministry is big on data. We are wanting to have data, microdata to the extent possible so that we are impacting lives in a more meaningful manner, more customized manner. Our intention is that I am proud to say that the Ministry of Tribal Affairs was probably one of the earliest ministries which kept emphasizing upon the debilitating effects of sickle cell disease on tribal population. More than 100 crore, more than a crore people, 100 lakh people had been screened for sickle cell disease way back in 2016, though much of that data is lost, and only those who are deceased are probably now following up. And there is also the element of social stigma associated with the disease. So when we were having our awareness and counseling modules being done under the chairpersonship of Dr. Deepti Jain, I remember she saying that we need to be very, very careful about counseling, premarital counseling, for the simple reason that there is a likelihood that the girl gets stigmatized. If a girl is found diseased, she gets stigmatized. So there is a need to look at the ecosystem in a very, very close manner where it's a stigmatized kind of a disease, where we are able to kind of overcome that stigma. Many of us have worked in areas where people are willing to come out and say, okay, I will not marry a person who is having the same disease, same genetic disposition as I do. So that has happened. But as Dr. Italia would be telling us, the counseling is extremely necessary, and it is doubly necessary because we all know that this is the place where we can stop the transmission of diseases. We can also help women to manage their own health in a better manner by the selection of their own life partners. So keeping all this in view, I congratulate NASCO and Mr. Dongre in particular for bringing all of us together on this very important day and focusing upon not merely sickle cell disease, but women suffering from sickle cell disease and what women can do to overcome that suffering and to help overcome that suffering, obviously with the support of all the men who I would also request to be as good women activists as some of us claim to be. So wishing you all again a happy Women's Day and hoping that the mission would succeed and that we are on the path to success, not waiting for 2047 to come, but we would be rid of sickle cell disease. I know the triad would continue to be with us, but we would be rid of sickle cell disease much before the deadline of 2047. I wish all of us the very best on that count, and thank you again for thinking of me and inviting me to this program. Thank you.
Gautam ji, can you take it for?
Yeah. Thank you so much, ma'am. आपने बहुत अच्छा आज मैसेज दिया है। आज के इस उपलक्ष्य में हम लोग बहुत बहुत आभारी है। आपने यहाँ अपना कीमती समय लेकर के हमें प्रेरित किया। डॉक्टर रुचिता पटेल, प्लीज कैरी ऑन। थैंक यू मैम फॉर एवरीथिंग।
We appreciate your enlightening overview on today's topic
It was a great pleasure to hear you, ma'am. Thank you so much, ma'am. Now we are
You're mute, Ruchita ji, you're mute. Please unmute yourself.
we have reached the next session of our conference, which is panel discussion. Today, we have two panel discussions with our eminent panelists. First panel discussion is Women Living with Sickle Cell Disease. How is equity of care delivered? Which is moderated by Dr. Tulika Seth, ma'am, Professor, Department of Hematology, AIMS, New Delhi, and our expert panelist, Dr. Lakhan Poswal, sir, from Rajasthan, Professor Dr. Pranta Chakrabarti, sir, from Tenkasi, Dr. Ruby Khan, ma'am, from Madhya Pradesh, Dr. Asmita Behra, from Chhattisgarh, Dr. Mahendra Kendri, sir, from Maharashtra, and Miss Roshni Meshram, Sickle Cell Warrior from Maharashtra. Welcome, ma'am.
Thank you. Thank you so much.
Over to you,
And,
ma'am.
I hope I'm audible.
Yes, ma'am.
Thank you. Okay. So the panel that we are going to be discussing is about the health inequity that women face. तो मैं हिंदी में भी थोड़ा सा बोलूंगी। औरतों को कई बार स्वास्थ्य सेवाएं लेने के लिए काफी दिक्कतें होती हैं, बाधाएं होती हैं, और उनको स्वास्थ्य के लिए असमानता होती है। So the first question I'm going to put to is Roshni here? Is Roshni connected? हाँ, रोशनी जी नमस्ते. Hello. I can see Roshni. So Roshni, आप जरा बताएंगे. So रोशनी जी, आप बताएंगे कि औरतों को क्या-क्या बाधाएं होती हैं स्वास्थ्य सेवाएं लेने के लिए?
हेलो हेलो.
हाँ जी, बोलिए. हाँ, बोलिए आगे रोशनी जी.
हाँ
स्वास्थ्य सेवाएं लेने के लिए औरतों को क्या-क्या दिक्कतें होती हैं, आप थोड़ा बताएंगी?
जी. एक्चुअल में फर्स्ट मैम उनको अवेयरनेस नहीं होता है कि उनको वो प्रॉब्लम जो है तो वो किसके साथ शेयर करे, और जब शेयर करने की बात आती है तो वो एक मतलब अस्पताल में जाकर भी वो किसी कोऑर्डिनेटर या काउंसलर के पास भी गए तो उनको अच्छे से काउंसलिंग भी नहीं मिलता है, और वो अच्छे से काउंसलिंग नहीं मिली तो उनको कंफ्यूजन क्लियर नहीं होता है, और आगे क्या करना है, ट्रीटमेंट कैसे लेनी है, हमारी लाइफ कैसे जीनी है, वो उनको थोड़ी दिक्कतें आती है. उनको समझ में नहीं आता कि इन सारे प्रश्नों का हल हम कहाँ से निकाल पाएंगे, कौन हमारी मदद कर सकते हैं. और उनके जो क्वेश्चंस होते हैं वो वुमेन्स के जो मेंस्ट्रुअल इशू होते हैं या फिर और भी प्रेगनेंसी रिलेटेड जो क्वेश्चंस होते हैं, उनको सारी प्रॉब्लम्स आगे जाकर क्या क्या प्रॉब्लम्स होगी, उनके मन में बहुत सारे सवाल आते हैं कि अभी हमारा प्रेगनेंसी टाइम पे हम मेडिसिन क्या ले, काउंसलिंग किसके साथ जाकर करे, बेस्ट काउंसलर कौन होंगे या फिर बेस्ट गायनाकोलॉजिस्ट कौन होंगे जो हमें अच्छे से गाइड करे, और इस वे में हम जा सकेंगे, हमारी प्रॉपर केयर भी हो पाएगी और हमारा न्यूट्रिशन भी अच्छे से हो पाएगा, हम हॉस्पिटलाइज भी नहीं हो सकेंगे.
So thank you, Roshni. आपने बहुत अच्छे से बताया. For our non-Hindi speaking listeners, I'll just summarize. Roshni described how often there is lack of awareness. When the women go to the hospitals, they may not be counseled appropriately and get full information. There can be some confusion about who to contact for the different medical and health needs. Many times they get overwhelmed with all the problems. They may be shy sometimes to ask about certain personal health problems. They will face a lot of issues during pregnancy and different time points in life, and many times they have many questions which remain unanswered. So that was very nice, and thank you so much, Roshni. You explained that very well. बहुत अच्छा आपने बताया. My next question is to Dr. Mahendra. Dr. Mahendra is the nodal officer for the blood cell NHM at Maharashtra. Namaskar, nice to have you here, sir. So I wanted to ask you, how can we reach women? There are women who may be patients themselves, or they may be mothers of the patients. So how do we reach out to these women? You just heard what Roshni ji described. इतनी सारी समस्याएं हैं लेडीज की. So हम उन तक कैसे पहुंच सकते हैं?
Madam, good afternoon, everybody. I first wish all the women on this Women's Day. And as the Roshni ma'am said, there are many problems they cannot express their problems in front of male doctors or female doctors, or they are not communicating. But right now, the state or from national levels, there are many ASHA workers at root level. They are approaching to their houses at when they will be found positive for pregnancy, and they advise that they discuss with the patients, and they carry these patients to our primary health centers, and the facilities for testing and the treatment is available at PSC level or sub-center level right now. The situation is changed. People are aware, and from health department, we are giving the awareness to all patients and all our ASHA workers. We are giving the trainings to all ASHA workers to discuss with the village people. So the situation is slightly changed, but actual situation, the ma'am was saying that this is the fact, but the situation is changed, I think.
So that's very reassuring. I think आप सही बोल रहे हैं, काफी इम्प्रूवमेंट हो रहा है. और ये NASCO के endeavor से, आप लोग सबके ब्लड सेल के endeavor से, Ministry of Tribal Affairs, everybody is working on this. I had a suggestion or maybe a comment that since you're saying that the ASHA workers go, can we collect some of the frequently asked questions? Maybe more material can be made, and maybe more training can be given to the ASHA workers, because I'm not quite sure that they would be equipped with the full knowledge in order to do this kind of counseling. And as Roshni said, that often the counseling is not so good. So I think we need to work a little bit more together and collect information. So thank you. That was very important what you said. I move to Dr. Asmita Behera, who's consultant blood cell NHM Chhattisgarh. And I wanted to ask if there is any collated statistics or data about the issues faced by women, particularly in pregnancy and also at other times. And the second would be your suggestion on how to improve the inequity that women face in accessing healthcare.
Hi, ma'am. Very good afternoon to you. So very sorry I could join only like 15 minutes back. The link was not working. I was trying hard for like half an hour. Yeah. So the topic you have raised, I think it's very relevant. First of all, ma'am, the thing is we have been testing women during pregnancy in Chhattisgarh, but the thing is, like what you talked about, like the issues basically. we have not worked a lot on that कि हाँ मतलब हमको ये पता है कि this death has been due to maybe like one of the causes has been sickle cell, but we really cannot say कि हाँ इसके साथ में कितना ज्यादा है. Recently what we have been doing, not just on women, we are discussing a lot of issues ki comorbidities ke sath mein sickle cell, how does it behave. So not just pregnancy, apart from other things also. So like it is possible that like for a woman only, like the women, because in our state specifically we have very high iron deficiency anemia also. So that also I think I need to stress on that also, because not just pregnancy but at least women and sickle cell when you are saying. So because we have a lot of comorbidities along with sickle cell in our state. So yeah, but we need to work on that. I cannot say that we have a lot of data on that. I can tell you कि हाँ pregnancy में इतना है, but maybe we need to go a long way on that front specifically. Yeah.
So any suggestions on how we can take this forward? Any endeavors that you have?
So ma'am, so what we were planning in between, so we have not been able to completely work on that. So we had planned something called as case studies. Case studies, what we had done, because we had a divisional, so we have 5 divisions in Chhattisgarh. Somebody is speaking, I think. Yeah, so we have 5 divisions in Chhattisgarh. So in between, what we were planning was, we want to study case to case, because unless and until we don't really, look into it as a case study picture, like one case was there कि हाँ मतलब उनको hydroxyurea, it was not benefiting the patient, or somebody else, like a pregnant woman has been, मतलब she was not taking hydroxyurea before or later on. तो ऐसे करके what we had planned was कि जैसे AIMS में we had a lot of patients. So like 2 case from AIMS, 2 case from Sarguja, which is again a very tribal district. So something like that we had planned. So I think that would benefit later on if we, because like we do not have a lot of proper data exactly what is happening. I have not seen कि ठीक है, this is what is happening to a patient and this is what we need to discuss. So we another was, we had twins also, some different kind of things, like one had sickle cell, another one didn't have a sickle cell, something like that we had planned. So that is still in planning stage. We have not yet completely gone that, but we are obviously going to do that in our state at least.
Thank you. Thank you so much. I'm delighted to have Dr. Ruby Khan with us. She is Deputy Director, State Hemoglobinopathy, NHM in Madhya Pradesh. So welcome, Dr. Ruby Khan. Dr. Ruby, can you enlighten us on the operational healthcare systems that are there? And are there any that are targeting women in specifically? And are there any government measures to decrease health inequity in women?
Good evening, ma'am. Thank you. Thank you. First of all, I would like to congratulate NASCO for arranging this wonderful workshop. And I think definitely in guidelines also, in target groups, the primarily target group were the women, which are those are pregnant women. So, and also with due course of time, like there are as the Vinita ma'am rightly said, they have developed a lot of training module or counseling module for the health workers, for the ASHA, ANMs, and even for the parents of those patients, like for sickle cell disease patients, and also for I think the school teachers, where these tribal children they are actually studying in the schools as well as in the hostels. They are the warden for actually the capacity building of these hostel warden is very important, because they must know, and along with that the screening of all adolescent girls as well as the pregnant women is important, and awareness among the patient themselves. As Roshni said, the patients are also not aware about the disease. Patient को खुद ही नहीं पता होता कि उनको actually कहाँ जाना है, क्या करना है, and the counseling part, even like the genetic counseling, अगर if they are carrier, so there is, especially for the woman, when she has diagnosed with she is a carrier, then there is a problem with the marriage of that female. So बहुत जरूरी होता है काउंसलिंग ऐसे लोगों का, स्पेशली जो डिसीज या कैरियर डायग्नोस होते हैं, फिर उनकी जेनेटिक काउंसलिंग अलॉन्ग विद द काउंसलिंग ऑफ देयर पेरेंट्स और उनके सोसाइटी में. तो इट इज बिकॉज in tribal, it is a totally different scenario. वहाँ पे उनको एक अलग तरीके से there is a stigma for them. So इसलिए अच्छे से explain करना. Even after marriage, the actual like training or capacity building or making aware the women themselves that they could get the prenatal diagnosis about the awareness about that कि they can, क्योंकि what happened in Madhya Pradesh, even we could मतलब we had offered prenatal diagnosis to some patient, and after diagnosis it came positive, but the woman was not ready for abortion, so they are not fully aware about the disease. So we feel that ki it should be in the guideline, and as always the counseling part is the most important part at every step of like in every age group, and especially the counseling of the woman or of the girl, that girl child or adolescent girl. It is very important for the marriage also, before marriage, like what we are doing, the genetic card distribution to those patients. So अगर उनको पता होगा कि हमें जेनेटिक काउंसलिंग करनी है या हमें हेल्प लेना है काउंसलर की, या फिर हमें ये पता होना चाहिए कि अगर हम इससे शादी करेंगे या फिर तो हमारे प्रेगनेंसी के चांसेस के मतलब पॉजिटिव प्रेगनेंसी के चांसेस क्या होंगे, और अगर प्रेग्नेंट भी होते हैं देन अबाउट द लाइक हर प्रेग्नेंट वुमेन को ये पता होना चाहिए कि उसे क्या कैसे न्यूट्रिशन क्या डाइट फॉलो करनी है, स्पेशली व्हेन शी इज सिकल सेल डिसीज, वो ऑटोमेटिकली हाई रिस्क प्रेगनेंसी में आ जाती है. अभी भी हमारे जो गवर्नमेंट की गाइडलाइन है, लाइक सिकल सेल पोर्टल इज नॉट कैप्चरिंग द प्रेग्नेंट वुमेन डेटा, दे आर ओनली कैप्चरिंग द like age and sex wise data but not pregnant woman data, जबकि बहुत जरूरी है कि उसमें अगर टैगिंग हो जाए कि ये प्रेग्नेंट वुमेन है, इवन द प्रेग्नेंट वुमेन की टैगिंग के बाद भी, सो इट रिक्वायर सम लाइक मॉडिफिकेशन इन द पोर्टल आल्सो. अलोंग विद दैट कि अगर वो प्रीनेटल डायग्नोसिस का अगर उसका होता है तो क्या फेट होगा, अगर उसकी डिलीवरी होती है तो व्हाट कुड बी द लाइक न्यूबॉर्न स्क्रीनिंग के लिए भी देयर आर द things which is not actually defined, but I feel it is, as it is already there in the operational guidelines, so this modification could be done. And especially these all things like comprehensive approach, like hydroxyurea, अगर एक adolescent girl डायग्नोज हुई, वो हाइड्रोक्सीयूरिया ले रही थी, तो उसको पता होना चाहिए कि जब उसकी शादी होगी तो उसको इमिडिएटली, या जब वो प्लान कर रही है प्रेगनेंसी तो उसे हाइड्रोक्सीयूरिया स्टॉप करना है. So these are the things which are there, and I think government is also working on it continue, because the lot of counseling material or the other things are available, but it needs to be reached to the last mile, like जिनके लिए बना है उन तक पहुंचना चाहिए. So I think it is very important, and I hope in with this kind of seminar this will reach to the last mile, और पेशेंट के पास, पेशेंट के परिवार वालों के पास, इवन हेल्थ वर्कर्स जो कि या फील्ड वर्कर्स हैं, उनको ये इन्फॉर्मेशन पहुंचेगी, तो वी कुड एबल टू सर्व दिस पेशेंट मोर एफिशिएंटली. थैंक यू मैम.
Thank you. Thank you. You summarized all the issues very nicely. And it's not an easy task. There is so much information that needs to come to them. The families have to, and the patients have to remember so many things. You mentioned the last mile. The Prime Minister actually is calling it the first mile, because that is actually the most difficult and the one that we have to bridge right at the beginning. So I'm honored to have Professor Prantar Chakravarti. He's currently a consultant at Zoho Corporation at Tenkasi, but he was previously the professor and head of hematology in NRS Kolkata, and he's a very knowledgeable person in technology. And we know that knowledge is power. So Dr. Prantar, can you highlight how technology can help, and is there any strategies that we can target these women, particularly maybe women who may not be very literate? Is there anything that we can do to bridge this very vital first mile?
Yeah, thank you, madam, and thanks for bringing these problems. Roshni ji started with, with the women not getting access even to information. So technology is there for information flow. And that is very important, because there is always a power distance. If a woman goes to a tertiary care hospital or a secondary care hospital, and she may be shy enough, and she might feel that sometimes what happens because of this power distance is that they even forget what they have to ask. So in that case, it is very important that the information flow uses technology. People look at Reels and TikTok and all these things so much. So we have to be creative with technology so that, as you rightly mentioned, कि उन लोग को कितना कुछ याद रखना है. वो जिस डॉक्टर के पास जा रहे हैं उनके पास भी इंफॉर्मेशन की कमी होता है. So for information flow, right, like we say about IEC, information, education, communication, it is technology which can help them. The technology already exists, but it has to be integrated. Second is care. We have to record each and every journey. If you talk to people, you'll see even the Secretary ma'am was saying about data capture. The problem is data is so fragmented, and we met some families 2 days back. They said their blood has been tested thrice, but after that they don't know what to do. And some say they have under some scheme or family folder. Some say there is an app. Information and technology can cross-talk. It's no use reinventing the wheel. सबसे इम्पोर्टेंट ये है कि अगर हम सिकल है नहीं भी है, हम कैरियर है, हमारा जो जर्नी है, as rightly Dr. Ruby said, a moment a patient is pregnant, the live dashboard should show these many are pregnant women, how are they being monitored, what are the problems they're being faced. And then you have internet-enabled technology, we call it now IoT or even AIoT, artificial intelligence of devices, where they can be remotely monitored. वो उसका काम छोड़ के उनके हस्बैंड का काम को बर्बाद करके वो कितने दूर जा सकते हैं. So it is very important that we use the technology for remote monitoring and also for flagging and escalation. कि इतने तक घर में हो सकता है. Institutional delivery in pregnancy is must, लेकिन वो जब टाइम दिया हुआ है उसके पहले अगर कुछ प्रॉब्लम होता है तो वो कैसे जाए. The third way technology can help is what we are doing right now. Similar groups of patients with similar languages and similar thought processes, they can be formed into a group and they can discuss their problems with each other. तो हम लोग इतना काउंसलिंग के बारे में बात कर रहे हैं, but I think the most effective counselor is the patient champion, the patient ambassador, क्योंकि वो उस रास्ते से गए हैं, उसको मालूम है और वो दूसरे से बात कर सकते हैं कि आगे क्या करना है. And technology is a great enabler there. It's not about only the big WhatsApp. There can be small social media chat groups. और एक fourth technology का रोल है coordination. कि जब आशा वर्कर और कम्युनिटी हेल्थ ऑफिसर लेके जा रहे हैं पेशेंट को किसी हॉस्पिटल में, तो हॉस्पिटल में जो जूनियर रेसिडेंट है, सीनियर रेसिडेंट है, जो इमरजेंसी ऑफिसर ऑन ड्यूटी है, उसको नॉलेज देने में भी ये ग्रुप्स और ये इंफॉर्मेशन फ्लो बहुत इंपॉर्टेंट है. इट टेक्नोलॉजी हेल्प्स अस इन मेकिंग इट अ कोऑर्डिनेटेड एफर्ट, और जिसका भी लिटरेसी रेट जो भी हो, जिसका भी भाषा जो भी हो, it is independent and it does not look at the status of the patient. That is the most important part of technology. और मेरे हिसाब से हम लोग को ये सब कुछ इस्तेमाल करना है. Thank you, ma'am.
Wonderful, beautifully said, and I hope we can implement all of the things that you have said. Yes, Dr. Asmita, you wanted to make a comment?
Yeah, I just wanted to make a comment on this because he was speaking about technology and how during pregnancy we should follow the sickle cell pregnant women. That's what Madam was saying, Dr. Ruby ma'am. So I just wanted to comment on that because in Chhattisgarh what we have been doing is we have been following high risk pregnant women, and in that everything covers. So sickle cell anemia has been covered in that, which makes more sense because I think like if we just make another thing for pregnant women in sickle cell this thing, because we have a very few numbers of pregnant women in sickle cell, but then we have a huge number in high risk pregnant women. So completely following them because it is possible that a pregnant woman who is sickle cell anemic might have some other problems also. So something like that, I think that is because the need of the hour, because I think that the maternal mortality ratio or whatever, unless and until you focus on high risk pregnant women, it is not going to help, and that has helped in our state. So I think that is one model which can be I think scaled up in all the other states also. So because from that only we come to know, okay, this person has had sickle. That's what I was talking about before also. This pregnant woman had sickle cell anemia and something else, and because of that, the deaths. So we do death audits or something like that, and then we can move forward like that. So of course I agree that you need technology, but also like where to use what, because I don't really agree that it can be merged with the sickle cell portal, because that is again a very different segment and it needs to be done with the pregnancy, like with the maternal health basically together. Yeah.
Okay, so that's another way of doing it. I think
Yeah.
that's also something that is already existing.
Yeah.
So that's a good idea. So with that, I move to Dr. Lakhan Poswal, who is the nodal of OESCD from Udaipur. And I also saw that he has done some work in medical education. So taking from what Dr. Asmita and Dr. Pranthal were saying about the pregnant women, one, I would want to know that in medical education itself, I
आप
don't
बताओ क्या बोलते हैं आपने कॉप के लिए अपने चार्ट भेज तो दिए
I don't know that we have the gynecologists are familiar with the management of sickle cell. So do we need to incorporate some of that into the curriculum? And then the other issue that was brought out by Dr. Roshni about the fact that often their questions are not addressed. So is that something that we need to again look at, because many times a male doctor or even a female doctor may address the most educated person in the family, and the questions that women have may get overlooked. So would you like to comment on both of those issues, please?
Good evening, Tulika ma'am. Good evening, Gautam ji, Ruchita, my colleague Lalit ji Pargi from Udaipur. I wish a very happy Women's Day to all the women power in this group and otherwise also. There is a lot of inequity in the sickle cell disease and women group, especially because sickle cell disease, as it's seen in tribal area, and they are already underprivileged, live in far reachable places, and women especially because there's a pregnancy and sickle cell disease a very very challenging situation. So we need to address this inequity in the delivery of healthcare facilities to women and those especially who are having sickle cell disease. Thankfully, with the National Sickle Cell Elimination Mission of Government of India, these inequities are going to be addressed, and the people who are living in the tribal belt are getting attention. The screening program has begun with them, because otherwise also the prevalence of disease more in them. And a lot of outreach programs have begun, because these people because of lack of education and knowledge about the disease and lack of facilities, resources, they cannot approach the healthcare system. So nowadays, with this launch of sickle cell mission, a lot of outreach activities, point of care testing, and medicines they are planned. There's a challenge regarding providing all the required things to the patient with the sickle cell disease, especially the nutrition. These patients need good nutrition, especially women should need they need good nutrition, and because of the poverty and lack of knowledge and lack of support and education, the nutrition of women is already compromised in our country. You must be knowing that a lot of stunting and undernutrition is there, especially in the women, up to 40%. Anemia is very rampant. And about the vaccination also, because they need a vaccination for pneumococcal, invasive pneumococcal disease, for meningococcus, for H influenza, for hepatitis B, and for flu also. And all these vaccines are not except for those who are born after 2017, after launch of universal vaccination for all children. For pneumococcus, influenza, of course, was given earlier also. But when we go to the programs organized by NASCO all over the country, we come to know that the children and patients with the sickle cell disease do not get free pneumococcal vaccine, meningococcal vaccine, influenza vaccine. So they are more susceptible to infection, and they can succumb to the serious invasive diseases. Fortunately, in our state, we have been given budget for procurement of these vaccines, pneumococcal vaccine, both conjugated as well as pneumo 23, for conjugate meningococcal vaccine, for flu vaccine. So we give vaccine to all those who are born after 2017, because they are also getting vaccine with the routine immunization program, national immunization. But to the people who were born before that, they did not get pneumococcal vaccine. Meningococcal is otherwise also not available in the routine vaccination. So this is a great inequity which has to be bridged at NASCO, and the advocates like us should pursue the government that not only in the routine immunization program, but beyond that also, all these patients who are immunocompromised because of the functional asplenia should get free pneumococcal, meningococcal, flu vaccine. Prophylaxis also, you see the availability of penicillin, oral penicillin B is not universally available. So that also needs to be addressed at the level of the policy makers. Research funding also is not given to those areas where the sickle cell disease is more. Fortunately, we now got a multi-centric trial on why VOCs are more in few people with sickle cell disease and not in others. We have to educate these patients about the hygiene, about the supplements, nutritional supplements, especially of the zinc, calcium, vitamin D, vitamin B12. In our area, we have a lot of patients with vitamin B12 deficiency. Very, very common, especially in the pregnant women, and that is why it is common in the infants also. Infants of age 3 to 4 months, even they develop nutritional tremor syndrome and all those florid manifestations of vitamin B12 deficiency. So they need vitamin B12 supplementation also. About the care during pregnancy, we recently had a pregnant woman who had VOC and was admitted for labor. So our gynae people were not well skilled. They never saw such situation. They might have seen, but now because we have created a lot of awareness in the other specialty, in the orthopedics, medicine, in obstetrics and gynae department. So now they have started thinking of sickle cell disease in all pregnant women who present with VOCs and other pregnancy related complications like miscarriage or preeclampsia or premature delivery, low birth weight, pregnancy induced hypertension, all those complications. So a lot of awareness has to be created, and you are right that though sickle cell chapter is given in our undergraduate curriculum, but that is not taught, with proper emphasis, and that needs to be, given emphasis in the undergraduate teaching, in the postgraduate teaching. It's only recently that we are, creating awareness about sickle cell diagnosis in the medical colleges, even in the teaching medical college, in the specialty departments. So that is very, very important. We have a lot of ignorance about these among the medical professionals. And as far as incorporation in the medical curriculum is concerned, I strongly recommend it to be incorporated, and all the questions needs to be answered. The questions raised by the patients, by the caregivers, by family members, by now, because this mission is going up to the Ayushman Bharat Health and Wellness Centers also, the screening program, HWC's level, Ayushman Bharat Health and Wellness Center level. So those people are unaware nowadays. We have seen that in the screening, two types of cards are given, two company cards are given, and the interpretation is different in the different centers. Yesterday only we reviewed our state level screening program, and in some districts, out of say 600 patients detected having sickle cell disease, 500 are having homozygous SS, sickle cell disease, and trait only 100. So this type of interpretation is, misinterpretation is done. So a lot of questions needs to be addressed. A lot of training has to be given to the Ayushman Bharat Health and Wellness Centers, PHC level, CSC level, wherever the screening is going on. So we have created a lot of sensitization, and I hope that with the progress of this mission, sickle cell elimination mission, we will be able to address all these inequities, and the health and happiness of the patients with sickle cell disease will definitely be much better in the future. Thank you so much, ma'am.
Thank you. Thank you, Dr. Poswal. You summarized a lot of the problems that we have, and as well as some of the solutions. And I think you've highlighted that all of us at every level, we still have a lot to do. So right from the doctors, I think we have to make sure that we address the issues of the patients. We have adequate training at all levels of the doctors, and it's important for those who are aware about sickle to share their knowledge with the obstetricians, with pediatricians, with other doctors, so that this gets disseminated. It is important for the people in the Ministry of Health to understand where there are gaps and to make sure that they fulfill them. And the question of oral penicillin availability and others came out quite recently. We visited Karnataka even, so there are many states that are having issues. The vaccine needs to be available. So there's many things that the NHM and the Ministry of Tribal Affairs has to look at. So I think it highlights that all of us, we've done a lot, but I think a lot more is required, and we have to keep working because our patients need it. And we want to be able to have a similar webinar in a few years, and we want Roshni and others to say, yes, that all of their questions have been handled and answered, and there is no health inequity. But as it stands today, we have a lot to do. So with this, I thank my esteemed panelists, and I hand it back to the organizers. And I wish you all very well, and a happy Women's Day, and all the best to NASCO and your endeavors. Thank you so much.
Thank you, ma'am. Thank you so much for beautifully moderating this panel discussion. And thank you all the eminent panelists for participating. We learned a lot from this panel discussion. Happy Women's Day to every beautiful ladies over here. Now, it's time to begin with our second panel discussion. Second panel discussion on tackling stigmas and socio-cultures, challenges faced by women with sickle cell disease, which is moderated by Dr. Dipti Jain, ma'am. Ma'am is ex-professor and HOD of Department of Pediatrics, Government Medical College, Nagpur. And our expert eminent panelists are Dr. Pariki Pandla Devi, ma'am, from Andhra Pradesh, Dr. Alka M. Patnakar from Nagpur, Dr. Anubhuti Rana, ma'am, from New Delhi, Shri Job Zahri sir from Chhattisgarh, Dr. Suman Jain, ma'am, from Hyderabad, and Miss Neha Verma from Sickle Cell Warrior from Chhattisgarh. Welcome, ma'am, and over to you, ma'am.
Thank you. We have got very eminent panelists, and so my job has become very easy. Hello, can you hear me?
Yes.
Yes, okay. So the eminent panelist, my job has become very simple, especially Dr. Sridevi, who has done her PhD on stigmas, social stigmas in patients with sickle cell disease. So I would like to start, Sridevi, I'm going to ask you the last because you are going to summarize and add whatever we all have not asked.
Yeah, sure, ma'am. Yeah, sure, ma'am.
We have Warrior. Neha was not able to join today. So we have Naz from Chhindwara, Madhya Pradesh. Naz, are you there?
Yes, ma'am.
Yes.
Good evening, ma'am.
Good evening. Naz, I've been knowing you for last, I think, 5 to 8 years. And I've always seen that in spite you being a sickle cell warrior, you have always made it a point to look at the social problems of patients with sickle cell disease. And today I would like you to share your experience with respect, you being a female. Yes, you are always accompanied by your relatives in all meetings, and though so patiently they wait and are always with you. So, can you share your experience?
Yes, ma'am.
आप
मैम
हिंदी में
जैसे
बोलिए
कि
नाज, आप
यस
हिंदी में बोलिए. आई थिंक हमें बताया गया था हिंदी में बोले तो अच्छा रहेगा. बोलिए.
यस तो मैम जैसे कि हम लोगों को सिकल सेल वॉरियर है और जो फेस करना होता है कि जैसे सबसे पहले तो हमको एक समाज में भी बहुत लोग ऐसे रहता है कि बोलते हैं कि बीमार है जो सबकी थिंकिंग एक बन जाती है हमारे प्रति कि हम एक बीमार हैं करके तो वो हम लोगों को वैसे ही ट्रीट करने लगते हैं सबसे पहली प्रॉब्लम तो हम लोगों को यही आती है फिर उसको लेकर के मतलब हमारे जो स्कूल्स में प्रॉब्लम रिलेटिव्स में प्रॉब्लम हर एक चीज में एक नजरिया जो हमारा देखने का रहता है हम लोगों को पर्सनल जो हम लोगों को देखने का जो नजरिया रहता है वो सामान्य लोगों के जैसे नहीं रहता मैम और इसके इसके वजह से बहुत सारी प्रॉब्लम्स झेलनी पड़ती है हर एक चीज में प्रॉब्लम होती है जैसे कि कई लड़कियों की और लड़कों की मैरिज में प्रॉब्लम आती है हर एक चीज में प्रॉब्लम आती है तो हमको इन यानी नॉर्मल लोगों से हम लोगों को इन सब में डील करना होता है मैम बहुत कुछ
नाज, बीइंग अ फीमेल, कुछ यूनिक प्रॉब्लम्स आप फेस करती हो वो आप शेयर करेंगी?
यस मैम मैम जैसे कि वुमेन्स में सिकल सेल वुमेन्स में ये देखा जाता है कि वो शादी तो करना चाहती हैं लेकिन वो प्रेगनेंसी से डरते हैं क्योंकि उन्हें पहले से यही बता दिया जाता है कि अगर वो मतलब प्रेग्नेंट रहेंगी या फिर उनको ऐसा रहेगा तो उनको हाइड्रोक्सी यूरिया छोड़ना होगा ये करना होगा बहुत सारे चैलेंजेस आएंगे तो मैम ये सब चीजों में वो डरते हैं कि जैसे नॉर्मल लोग इतना नहीं डरते जितना मतलब इस वजह से मैम वो लोग प्रेगनेंसी से भी डरते हैं और शादी से भी डरते हैं मैम ये सब फेस करना होता है कभी कभी ऐसा होता है कि अगर हाँ सबको तो रेडी है शादी के लिए लेकिन वुमेन्स में ये रहता है कि वो अंदर से खुद भी डरती है और दिखाती भी है कि वो बहुत मुश्किल से इस चीजों को एक्सेप्ट कर पाती है मैम चाहते ही नहीं है वो लोग ये एक्सेप्ट करना
ठीक है, अब तो थोड़ा बदल रहा है. मैं मानती हूँ कि वुमन प्रेगनेंसी और शादी से डरते हैं, सिकल की वुमन, बट अब काफी लोग शादी कर रहे और अपन देख रहे हैं. अभी बात चल रही थी कि प्रेग्नेंट एसएस वुमन कितनी सारी है, जो हम बात कर रहे थे, है ना. तो चीजें बदल रही हैं, बट मैं जरूर मानती हूँ कि ये एक इश्यू हमेशा दिमाग में आता है. अब भी मेरे पास एक प्रेग्नेंट लेडी है जिसने हाइड्रोक्सीयूरिया बंद किया हुआ है, एंड वो इतनी सीवियर क्राइसिस में गई हुई है बिकॉज ऑफ प्रेगनेंसी, सिकल सेल. तो अब कितनी बड़ी ये आ गई है, हाइड्रोक्सीयूरिया देना है, पेन इतना हो रहा है, पेन किलर से वो नहीं हो रहा, बार बार पेन हो रहा है उसको। तो ये जो एक स्पेशल प्रॉब्लम है, प्रेगनेंसी, मैरिज, टेकिंग केयर ऑफ चिल्ड्रन, ये वुमन के लिए ज्यादा होता है। माय नेक्स्ट क्वेश्चन टू डॉक्टर सुमन जैन मैडम. Madam is the Secretary and Chief Medical Research Officer at Thalassemia and Sickle Cell Society of Hyderabad. She has vast experience in treating patients with sickle cell disease. Madam?
Good evening, madam.
Good evening, good evening.
Thanks for kind introduction. And thanks to Gautam also to include me in this panel discussion. And हाँ, हमारे पास बहुत लेडीज माने वुमेन्स हैं, और हमारे 700 बच्चे अभी हमारे पास रजिस्टर्ड हैं, एंड हाईएस्ट एज अभी हमारे यहाँ पे सिकल सेल का अराउंड 35 ईयर की बच्ची वुमेन है। हाँ, जो नाज ने कहा कि हाँ लड़कियों को प्रॉब्लम आती है, ये प्रॉब्लम तो है, दैट सोशल स्टिग्मा जो पहले था, जो 2016 बिफोर दिस गाइडलाइंस हैज बीन मेड, उस समय ये प्रॉब्लम्स ज्यादा थी। और अभी जो मैं देख रही हूँ, एंड यहाँ पे जिन्हें मेंशन भी किया है कि सेल्फ हेल्प ग्रुप, और जो हम लोग अपने ग्रुप के साथ मिलते हैं, तो ये जो प्रॉब्लम्स है जो हम लोग एक दूसरे से शेयर करने से काफी कम हो जाती है। तो ये प्रॉब्लम अभी हमको उतना फेस करने को उतना सोशल स्टिग्मा नहीं है, बट आई एम वेरी श्योर कि प्रेगनेंसी के लिए डेफिनेटली प्रॉब्लम आती है। बट आजकल बच्चे लोग इतना अच्छे कैरियर्स में आगे बढ़ रहे हैं, दे आर बिकमिंग doctors, they are becoming nurse, they are becoming engineers. The thing is that somebody has asked me to talk to English, like the language English में मैंने many patients are so much confident now in our society who are coming to us. They are coming from urban also and the rural areas also. But we have to talk to them in a confident way, and we have to increase their confidence and self-esteem so that they can do very good in life. And once they are established in their careers in some way or other and start earning, so they become more confident, and automatically they can go for the marriage also. And pregnancy, we have to have a safe pregnancy, in the sense they have to be with the doctor very early in life, very early in the pregnancy, not going in the last trimester, because we have faced a lot. And one pregnant woman, she was a sickle thal patient, and she came to us at 7th month of pregnancy. So that time, and again she had a dengue that time, and we lost her. So it should not be like that. In pregnancy, they have to be, hydroxyurea has to be stopped, and they have to continue with pregnancy. And the sickle cell में pain crisis आ सकते हैं, वो time पे they have to take care under the good guidance of the gynecologist, and also the hematologist should also be there along with the gynecologist, and so that they are trained and the good quality and the outcome will be good. So many sickle cell patients have been diagnosed only during pregnancy. So they have gone through and they have given the good birth to the child, and luckily the child was carrier, and the patient was registered with us, and now they are having a good quality life, having hydroxyurea. So I mean to say the social stigma is there, but we have to nullify it by doing awareness and community awareness and taking good care, because it is a genetic disorder like a diabetes and any other disorder, and we have to accept it. If you are a sickle cell anemia or a coma or a double heterozygote, we have to accept it and deal with it. And automatically some people, all other specialists are there with you. You have to take care of us, take care of yourself. And then I think the sky is the limit, and anybody with the disability, they are doing wonders. And I congratulate to them and have a good confidence and do go further in life. Thank you.
Thank you, madam. I think pregnancy is one thing, but I think from childhood till adulthood, females have different problems. Pregnancy is one of them. I have a mother who comes to me, the daughter is 16 years old. 16 years back, she did prenatal diagnosis with me. Dr. Alka is here. She has done, she's the one who did amniocentesis those days. The baby turned out to be SS. The husband left, the in-laws left, and that girl is today 16 years old. And that lady is living alone with that girl, and it is a severe type of sickle cell disease which she has. So such social problems, I think, are coming a lot to us, I think we also talk how to deal with them. We also have Mr. Zakaria. He's in UNICEF, and he is experienced in the field. Maybe he'll be able to show some light on what is the rural woman having sickle cell disease, female working in rural area. Mr. Zakaria, is he there?
Sorry, ma'am. Actually, he is in a government meeting, so he excused.
So maybe the next person is Dr. Rana. Rana, she's an assistant professor of obstetric and gynec from AIIMS, New Delhi. And you've been hearing about pregnancy, Dr. Rana. And maybe you must have faced such issues, and how did you tackle them?
Good evening, ma'am, and thank you for the kind introduction. And thank you to the organizers and NASCO for having me here. Ma'am, I have been working as a maternal fetal medicine person, and over the last 5 years, हमने देखा है कि ट्रेंड्स काफ़ी चेंज हो रहे हैं. जो पेशेंट्स पहले बिल्कुल ही ना इस बात को बताते भी थे, कई बार बताने के लिए भी बहुत हिचकिचाते थे, वो अब काफ़ी ओपनली प्रीनेटल डायग्नोसिस के लिए हमारे पास आ रहे हैं. तो बेस्ड ऑन द ट्रेंड्स मुझे लग रहा है कि मैम अवेयरनेस जितनी ज़्यादा गवर्नमेंट और गवर्नमेंट प्रोग्राम्स की वजह से हो रही है, तो चीज़ें काफ़ी बदल रही हैं मैम.
आपको कभी कोई ऐसा यूनिक चैलेंज मिला while dealing with pregnant women or in any obstetrics and gynecs? कोई hemoglobinopathy का पेशेंट हो?
सो मैम एक बार 2 पेशेंट्स मुझे आज तक याद है मैम. एक पेशेंट हमारे पास 32 वीक्स पे रेफर हुई थी एंड शी हैड सिकल सेल डिजीज, एंड उसका पेन मैनेजमेंट बहुत मुश्किल था हमारे लिए. जब हमने हाइड्रोक्सी यूरिया बंद किया, द अमाउंट ऑफ हाइड्रेशन वी मेंटेन्ड, कितनी बार हमने एनेस्थेटिस्ट से बात करके, द पेन रिलीफ वाज अ बिगेस्ट चैलेंज. एंड इट वाज एक्चुअली बहुत मन दुखता था कि इतना ज्यादा पेशेंट पेन में है. फाइनली शी वेंट इनटू स्पॉन्टेनियस लेबर, डिलीवर्ड अ हेल्दी बेबी. तो मतलब फैमिली भी खुश हो गई, बट शी वाज इन अ लॉट ऑफ पेन एंड इट वाज वेरी डिफिकल्ट टू मैनेज दैट पेन. एंड आई हैड वन पेशेंट मैम. बाकी तो प्रीनेटल डायग्नोसिस बहुत सिंपल है, बट इन प्रीनेटल डायग्नोसिस one patient diagnosed with SS, sickle cell disease, but the patient did not opt for MTP. So that was a very difficult situation for me to explain to her the consequences, and despite everything possible, she did not opt. So unfortunately, that there is still some patients who do not accept this and are ready to continue pregnancy.
Yes, we do find that. And most of the time, the reason is because I think counseling is very important, awareness and counseling, even for females. That even before going for prenatal diagnosis, be sure that if the baby is a sufferer, you may go for MTP. But then that time they agree, and I think in a month, I get one patient that after getting the report, they say, nahi, hamare ghar wale mana kar rahe. You can't do it. This option is theirs, but this is common. But it always, my greatest problem, I would say, being a female sickle patient, I see is when they come for prenatal diagnosis, counseling, the mother-in-law is always there. The mother-in-law is always there with the husband and the wife. And when I start saying that you are Vahak, yes, this girl, when the son never had a sickle cell. There is no sickle cell in my family. Because he got married to this girl, he has got sickle cell. So now I've changed. The first thing I tell them is, ये बीमारी दोनों में है, आपके फैमिली में दिखी नहीं होंगी। द गर्ल, पुअर गर्ल कीप्स ऑन क्राइंग कि मैंने मेरे हस्बैंड में ये बीमारी लाई है। आई थिंक ये सोशल जो प्रॉब्लम्स है ना, वी एज डॉक्टर कैन टैकल। आपके वहां पता नहीं वो घर जाके सास बोलती होंगी क्या बोलती होंगी, मगर मेरे यहाँ तो मोस्ट ऑफ द मदर इन लॉ विल से मेरा बच्चा तो अच्छा खड़ा था, ये आई उसने शादी की और बच्चे को भी लग गया ये बीमारी। पहला सेंटेंस हमारा ये रहना चाहिए। ये कितना बुरा स्टिग्मा है हमारे लिए, लड़की के लिए। लड़की को बोलते हैं वो कि उसने बीमारी लाई मेरे घर। आई थिंक ये बहुत कॉमन है। एंड आई थिंक मुझे मैसेज दूसरे डॉक्टर्स को और बाकी लोग भी जो सुन रहे हैं उनको बताना है कि ऐसा कुछ नहीं है, एंड ये हमने मैसेज स्प्रेड करते जाना चाहिए। अब नेक्स्ट इज टू डॉक्टर अलका. Alka is a very experienced, she's a professor and head of obstetrics at Indira Gandhi Medical College, Nagpur, and she has been doing prenatal diagnosis for last 15 years. Alka, with me, she was working. So she has many experience about women and sickle cell disease. Alka, can you share your experiences, please?
Yes, madam. At the outset, I will like to wish you all happy International Women's Day and thank NASCO for inviting me in this session. About sickle cell disease, we have many patients, and I had a privilege to work in a tribal medical college where sickle cell anemia is rampant, that is Chandrapur GMC. At any given time, we used to have minimum
Yes, Alka, we cannot hear you.
Two sickle cell disease patients may be the case. It's a very close knit community, and there are marriages in the community, and carriers are in plenty, and that is why SS pattern patients are more. But to my surprise, there is no stigma. They accept SS patients so well. Many of them are not aware because of poverty, because of lack of education. They are working in the fields even when they are ANC with sickle cell. They get admitted with anemia, and on investigations they are detected to have sickle cell disease. I was always very surprised. And what I saw is the vaso-occlusive crisis were less as compared to anemia. They used to come with severe hemolytic anemia. If they had this vaso-occlusive crisis, might be they are detected earlier and then they know the severity of the disease. Otherwise, and one more thing I will like to, as these children are brought up right from the childhood, their parents see them suffering, and they are very dedicated. To me, I have two daughters, SS pattern, and hello, am I audible?
Yes, we can hear you now. Yes.
Yeah. So a family from Chindwada, I know them. Two of their daughters, they are SS. One is married, and her husband was also AS. We had done her chorion villus sampling, and the child was found to be AS. They continued the pregnancy. She delivered. She had received 9 units of blood transfusion during pregnancy. The baby weight came out to be 3.5 kg to our surprise. Now the child has grown to 14 years of age, and I tell you, the parents of the girl, they are very dedicated. Most of the time the family is at her paternal place, but she is being taken care of by the parents even when her son has grown to the age of 14. So I feel that groups of parents should be formed who are having their children who are sufferers, and they should be the torch bearers to propagate how to take care of these girls during pregnancy. And see, these parents, they are so much motivated that when they go for the marriage of their daughters, they usually do it with full information to the in-laws. I only had come across one patient whose in-laws were fighting in front of me in the OPD, blaming the family that the family never told that the girl is sickle cell disease. And the girl had never suffered since her childhood. She had never received blood, and that is why the parents were not aware that she is a sufferer. She is SS pattern. So these kind of patients, they need a lot of counseling. And as for prenatal diagnosis, whenever the patient, 15 days back, I got a patient from Balaghat who herself was SS pattern. Husband was AS. She had come for prenatal diagnosis. The doctor had not talked to her what are the consequences of the reports, what possibilities of the reports, and whether she will like to abort a child if the child is having a hemoglobinopathy, which she is having. The first thing nowadays, I ask the patient, telling them that, see, you have been referred here for prenatal diagnosis. She said that, yes, madam, हमारे मैडम ने बोला पाटनकर मैडम के पास जाओ, वो टेस्ट कर देंगे आपकी. मैंने बोला कौन सी टेस्ट करनी है आपको, तो बोले ब्लड टेस्ट. मैंने बोला इट इज नॉट ब्लड टेस्ट, it is the test of your fetus in utero that we are going to do. And if the report comes as SS, are you willing to go for abortion? She said flatly, no, we don't plan to go for any abortion. Then I said, I wish you all the best that your child will come normal. That is my wishes. But I respect your decision because that's your life and it's your choice. So whenever the patient is sent to such centers from long distance, doctors also need to be counseled properly. They should be trained properly at PHC level, at sub-center level, what prenatal diagnosis means. Otherwise, they just send SS patient with AA pattern husband for prenatal diagnosis because the patient is suffering from sickle cell disease. So this training needs to be imparted to avoid inconvenience to the patient. That is what I want to tell.
Very right.
Thank you so much.
Very right, Dr. Alka. And I agree with you. The culture, many of the culture in tribal area are much better than non-tribal area. Unfortunately, in Nagpur, we have these, and it is more severe than the tribal population, which is there in Chandrapur. Right now, the thing is, it is marriage and pregnancy. These are the two main social stigma for women where they face many challenges. Yes. Now we go to Dr. Sridevi.
Ma'am, sorry I just wanted to inform that Job Zakaria sir has joined.
Okay. Welcome, Dr. Zakaria. Mr. Zakaria.
Thank you.
Yeah, so we were talking about the social stigmas in women with sickle cell disease. And so you have a vast working with UNICEF. You have vast experience in field, right? So what are your experiences regarding this social stigma in sickle cell females?
Thank you. I just want to relate an example. When what I found, I was in the Jashpur district last week, and then I came to know about a case where now, as we know that in all pregnancies, they are testing for screening for SCDs, sickle cell disease, and HIV, and for syphilis. And this girl, this woman was found she is a carrier, and that led to a lot of discord in the family. So what we see is now in Chhattisgarh, already about 1 crore people have been tested for sickle cell disease. So even if they know about it, because of the stigma and the discrimination in the society, there are 2 levels of discrimination. For example, if you are a girl and or a woman, and then you are tested positive, you tested for whether for trait or for disease, then your chances of getting married and other implications are there. So the people tend to keep it as a secret because of the stigma prevalent in the society. So the one biggest hurdle will be that, the first thing we need to probably do is to screen everybody, I mean, entire population. That is what in Chhattisgarh we are doing now with this government has initiated on the mission. And so far, about 1 crore. I mean, the idea is to screen about 1.8 crore. And so far, the prevalence rate is about 3%. So far, whatever the data which has come is, I think it's about, the government has not announced released the data. So the stigma, this is a reality, it exists. Thank you.
Okay. Is there anything which female sickle cell are not allowed to do, like some ceremonies I've heard from some mothers? Because they have sickle cell disease, they will not be invited to for a particular function, or anyone. I think anyone of the panelists can talk on this. This is a very, I think, serious social issue. If this is done, it's literally a torture. Has anybody heard about this? Sridevi?
Yes, ma'am. Good evening, ma'am. Ji, ma'am. Yeah. So, good evening, all of you. It was so nice to hear to all from the afternoon, from the starting of the program. It's lot that I have done my PhD, ma'am. I have done my PhD in endocrinology, but then I have been working now in the field on sickle cell disease in the ICMR National Task Force project since almost 6 years now. We have been working on sickle cell disease. So I have little experience, and now the work what we are doing is exactly stigma in sickle cell disease patients. We have a cohort of patients in 5 districts all over India. And what we have observed in stigma, as you were saying, there are different kinds of stigma what patients are facing. Actually, the problems which are faced by men and women are not very different, but then women suffer more because of the stigma than men. Though men little overcome the stigma, but listening to Nomesh Verma today, I am very sad about it, but even they also undergo this stigma. Women also have so many problems like family, in the workplace, or because of their pain and the crisis levels and the hospital visits. Because of that, they undergo more stigma, and they are stigmatized in the society. And what we have observed, especially in the tribal areas where we are working, the stigma is more than the urban areas. At least in the urban areas, what we have observed is because they go to the doctor and they take the medicine, and every day they try to live or manage the disease and try to live a normal life. And hence they overcome the stigma. But when you come to tribal areas, first of all, they are not allowed to go to the normal government healthcare system, what we have observed, because they go to the traditional healer. Only when the pain is there, they go to the traditional healer and they get the pain. After what we are doing, all awareness programs like Dr. Alkaji or Suman Jain madam were telling, because of the awareness programs and all, now they are going to the government healthcare system. They are going, but then they sometimes they skip the medicine. Or if they are continuously going to the hospital, because of the stigma, they are stopping going to the hospital. That they are not unable to accept, their families are unable to accept that they have some problem. Because of that problem, because of the pain and all, they are not able to do the everyday daily routine things, and they are being stigmatized. And because of that, slowly they have stopped going even to hospitals in the tribal areas. When we are working in the tribal areas, we are going and counseling them that at least you take this medicine. You can be a normal person. Normally you can have a normal this thing. But what we have seen that, as you were telling, marriages, during marriages, it is a biggest thing. Not only the sickle cell disease patient, their family members are even being stigmatized. Means the family members even are in the family, there is a stigma patient, and hence do not go for an alliance with that family. In that way, even the total family is being thrown away from the community. This also is happening in the tribal areas. And coming to the women, they are suffering more because because of that women, we have in our cohort, we have some unmarried girls also who are sickle cell disease patients, and who stopped their education also because of sickle cell disease, and later they are not even married because of this stigma. And in their families, they are even kept away. In their families, their sisters or brothers, they were like told because of this is a genetic disease. Now, because of awareness also, now it is a problem. Before they were thinking that it is a infectious disease or something. It will be cured. Now, when they came to know that it is not a curable disease, it has to be managed all over their life. Now the scenario has little more changed. Now, because if someone has an alliance in that family, they have to manage the disease whole of their life, and hence people are not even getting married. And the card system, which has been introduced even in the sickle cell mission, we have not introduced in our project, because what we observed in the starting itself is that the family which is having a card are being kept aside. Means, oh, this is a genetic disease, not to get married. So even the counseling and awareness, now we started, like in the first starting itself, Tulika ma'am was telling that we tried to train the ashas that this disease can be managed, and it is not that they should not get married. Like you were telling, the prenatal diagnosis may help if they are not SS patients. The alliance can be done, and even if it is an SS patient, they can marry a normal person. So we are even training the ASHA workers. This might work, ma'am, even in the rural and tribal areas. That can be a little change, but the stigma is very, very high in the tribal areas, and women are suffering more because neither they are able to attend any family functions or festives. They are kept away, and because of the brain crisis and pain they suffer, they are unable to do the daily routines, and neither they go for the everyday, the tablet or anything. They miss the medication. We are also even trying to tell them that this all stigma, or this all can be, you can overcome with last week we had a patient in our cohort who died because he was continuously going to hospital and taking hydroxyurea and even the iron tablets and etc. But after some time in the community, they came to know that he is having medication, and they started, targeting him. So slowly, what he has done is he has kept away from hospital, going to hospital and all that. And because of brain crisis, we lost him from the cohort. So these are the few things which I wanted to tell. And if you want me to tell more, yeah, I do have much on stigma. Yes, ma'am.
I think from what we have talked today, of course, Sridevi, you will add more to it later. Education and awareness campaign, very important. There should be empowerment program for women, like skill development, where they work with other women and they know their rights. Collaboration with healthcare people. We are just neglecting mental health of sickle patients. Like what I've learned, whatever I know today is from my patients, not from the books. Patient comes, nobody asks them. Since they come to us from childhood, I just say, now, where is she? What is she doing, your daughter? Oh, she's a professor in one of the colleges. I said, very good. And she's going to do PhD. So the other patients are also listening. So sometimes we have to talk apart from our medical work. Next would be, what about marriage? The mother will say, oh, girls can't get married. Sickle cell girls can't get married. It's not so. So we have to know from there what are their social issues. Sitting without talking to them, I will never know what are the social issues with the family, especially the girls. And I think things are changing now. Imagine they are faculty in colleges, they have become doctors. Many of my patients are doctors and in IIT. And still they continue to have that, but male are more. I'm talking of some females, but marriage for females, no, not possible. That is one thing you have to ask the mother. The mother thinks she cannot talk to me about it. And it helps, because I wanted to end today's this social stigma. I think it is the worst thing. We talk about diagnosis, vaccines, medicines, many things. But the worst thing is this social stigma, which I've been seeing since years. And I wanted that we should keep hope and continue our work, because last week I got 2 of my patients, both females. The father came to me to give me an invitation card. Madam, we looked for whether the boy is AS or not. We asked them when they came to see our daughter, whether our daughter is AS. So is your son AS or normal? We told them. I said, if they would have said, then we don't want to marry, I would not have married. I had 3 proposals were refused because my daughter was AS, but I continued that. I was so happy to see that. And the second one was a professor in a university. She came to me and I said, she came with, the mother came with her and said, there is a boy who likes her, but she is SS. So the mother, who is a doctor, says, first find out whether she is AS or SS. If she is SS, we will not marry. So she said, can I bring the mother to you? Yes, they were from Chandrapur. The mother, means to be in-laws, the father-in-law, the whole family came. And I explained her, see, what even I used to think 25 years back, that SS cannot live a normal life, is no more true. Believe me, that this girl is been with me for years, and now 28 years. And believe me, she has not any serious problem, and she can have a happy married life with proper precautions and medicine. Then they went back. Now, just 3 days back, they came with a packet of peda that, yes, they've agreed to get married. So I think these things we can overcome, giving some time, each one of us, not doctors, everyone in the society. Today, I'm happy that they're from other professions also. Each one of us, if we can look at this mental health, social health problem, we can really, I think, release most of that stigma and mental tension. Yes, over to you, Sridevi now. But I want to say things are improving. I say from my experience. Yes.
Ji ma'am. Yeah, these examples are really, I mean, very encouraging. But the same thing, like you were telling, the empowerment programs for women and mental health of patients have to be addressed even in the rural and tribal areas. Under the sickle cell mission, which has been taken up, more than screening and all, whoever of the patients are there, first the awareness has to be increased. For example, the awareness, I have worked earlier in Madhya Pradesh, in Anuppur district. There in the whole district, we have worked extensively on the awareness programs. And today, we see that they are totally, I mean, even the medical officers, ASHA, ANM, on the diagnosis part also, they are very, very confident. So the awareness programs will play first major role, ma'am. And then the awareness of the patients themselves really plays a role, that this disease can be managed. That is the confidence what has to be filled in them. That confidence filling later, then managing the, see how we, when we get a fever, if it is a prolonged fever for a 1 month or a 2 months, then how do we manage? In the same way, it has to be managed. And if it is managed and they can be normal, that has to be filled in them. Then they can overcome more stigma in the community also. That's what we understood in the tribal areas. Though leaving the rural and urban areas, tribal areas, actually it is more tougher, because these people have set of, the tribal areas have set of things that, first of all, they never even disclose. They don't even try to disclose that they have something. And if they try to disclose also, they will try to tell that I have some pain, मैं अभी ठीक हूँ, थोड़े दिन में ठीक नहीं थे, but I am okay now. And again they fall sick. So what happens in the community is they fall ill again and again is coming. So that has to be reduced slowly. Once the acceptance increases, even by the patient himself or the family, the caregivers will be the major role players in this. If they accept it once, and because of the awareness, if the awareness is done properly, if they start accepting the disease, later slowly the stigma can be reduced. So in our work, what we are doing here is we are trying to develop a stigma scale in the sickle cell disease patients. I mean, it's not gender based. It is like overall in the rural and tribal areas. That's what we were working on. Now we are collecting which kind of stigma they are even suffering from. So this is about it, ma'am.
Okay. But I want to tell our community screening, which we are doing, will work. Why are we doing detecting? Mainly we are detecting carriers. Why are we doing that? We want to tell them, and we never tell them don't marry, but we just tell them the chances and then opportunity at pregnancy to detect that there is not a SS child in their family. We have to explain them. And the girl has to be convinced. And most of the girls are now educated, even sickle patients. So I would think that if anybody else wants to add anything, because we didn't have a second round for the panelist. No? Okay. Then I think I congratulate Gautamji for bringing this topic, because, you know, initially I never thought that social stigma, yes, social stigma, I didn't, okay, hai kuch word aisa. But when you see the patients going through it, it's really very, you keep on thinking about it, and you want to do more about social problems also, as you do for the medical morbidity that they have. And I think each one of us, if we are committed to this, it will definitely, the sickle cell patients, we give them support, empowerment, they will be free from stigma and discrimination. Gautamji?
Thank you so much, ma'am.
Yeah, congratulations, Gautamji and Dipti ma'am and Tulika ma'am and all the participants for bringing out such a wonderful topic. This is very important, actually.
Yeah, it's needed, ma'am. Thank you so much for participating and throwing lights on the social stigma. Thank you all.
Thank you.
Ruchita ji.
Thank you.
Yeah.
Thank you so much, ma'am, for beautifully moderating this panel discussion. And thank you all eminent panelists for participating. And we learned a lot from these panel discussions. We discussed social stigma. We faced, as a sickle cell disease warrior, we faced social stigma. We faced more challenges to day-to-day routine life. And you all are connecting with us to discuss our problems. We and our NASCO teams are so grateful to you people. And we are so grateful and we are so happy that having you all in our life. We are now concluding our beautifully moderating this panel discussion and this online webinar, Women and Sickle Cell Disease. We congratulate all of you and all the women who are present here. Thank you so much for coming and connecting with us. Thank you so much, each and everyone, to present over here and discussing the social stigma, the day-to-day routine life, the screening problem, the each and every treatment problem regarding sickle cell disease. You all are expertise in the sickle cell disease, and we are so learned a good knowledge about each and every disease perspective, the different state and different people around the India, and each even in the now we are connected to the globally. So we are knowing the different perspective about sickle cell disease, the treatment level, the screening level. the knowledge about sickle cell disease. So thank you so much, each and everyone. Now, concluding this webinar and with celebrating the life of Nomesh and memories of Nomesh, we are playing a video. Thank you.
Thank you so much once again from National Alliance of Sickle Cell Organizations of all of you. आप सभी का बहुत बहुत धन्यवाद। नोमेश की यादों से आज का सेशन शुरू हुआ था। नोमेश को देखकर हम कंक्लूड कर रहे हैं और आगे ऐसे किसी नोमेश को हम खोए ना, इस उम्मीद और आशा के साथ आप सभी भारत के अलग अलग कोने से, विश्व के अलग अलग कोने से सिकल सेल के लिए आपने आज जो यहाँ विचार मंथन किया है, इसका बेनिफिट हमारे जो पिछड़े पेशेंट्स हैं उन तक पहुंचे। इसी कामना के साथ हम मिलते हैं। और साथ ही मैं धन्यवाद देना चाहूंगा कि आज के सेशन में आज सारे एक्सपर्ट्स उन्होंने अपना कीमती समय यहाँ दिया है। मिनिस्ट्री ऑफ ट्राइबल से कीमती समय आया है, कॉर्पोरेट्स नोवो नॉर्डिस्क से। मैं नोवो नॉर्डिस्क का भी धन्यवाद दूंगा कि उन्होंने आज के वेबिनार के लिए सपोर्ट किया है। और सारे पेशेंट्स, सभी ऑर्गेनाइजेशन जो देख रहे हैं, सभी का बहुत बहुत धन्यवाद। थैंक यू सो मच फ्रॉम ऑल।
Congratulations, Gautam ji, for successful program.
थैंक यू सर, आपके आशीर्वाद, आप सभी के आशीर्वाद से ये कार्यक्रम सक्सेस हुआ है। बहुत खुशी भी है और बहुत सारी चीजें सीख कर जा रहे हैं कि आगे किस तरह से हमें सिकल सेल से मुक्त होना है। आप सभी का जो महत्वपूर्ण गाइडेंस है वो बहुत लोगों की जान बचाने में काम आएगा। तो ये वक्त आपका जो आप सभी ने दिया है वो बहुत कीमती है और हम बहुत बहुत आभारी है।
Thank you, Dongre. Thank you, Dongre ji, and everybody. It was a very good. I couldn't leave because मैं सुनती रही सबको। समझने के लिए बहुत कुछ सीखने को हर रोज मिल जाता है। तो इतनी देर सुन के बहुत सारी चीजें, कई चीजों के कंक्लूजन्स पे पहुंचे कि जो करनी है। तो लेकिन मदद सबकी चाहिए क्योंकि अकेले सरकार उस कार्य को नहीं, सब मिलके कर सकते हैं। तो बट आज का जो सेशन था वो बहुत ही इंस्पायरिंग भी था और बहुत ही लर्नेड था। लर्निंग बहुत अच्छी रही मेरी स्पेशली, क्योंकि हर दिन मुझे एक नई कुछ सीखने को मिल जाता है। सोशल स्टिग्मा के साथ साथ मैनेजमेंट पे जो इश्यूज मुझे लग रहे थे उस पे भी मिनिस्ट्री ऑफ हेल्थ का दिमाग, मतलब उसका रुझान उनका लाना पड़ेगा कि अनटिल सेंटर्स हमारे उतने बढ़िया बन जाए, इवन अगर हम पीएससी सीएससी तक स्क्रीनिंग कर भी रहे हैं वो जरूरी भी है, लेकिन साथ साथ मैनेजमेंट भी उसी लेवल का अब लाना जरूरी है। और स्पेशली वुमेन और उनके उसके लिए मैं चाहती हूँ कि एक स्पेसिफिक गाइडलाइंस मिलना बहुत जरूरी है, जिसके लिए मैं रिक्वेस्ट भी करूंगी मिनिस्ट्री ऑफ हेल्थ से भी, और साथ साथ आप सबसे भी रिक्वेस्ट करूंगी कि अगर ये अलग से भी बनाई जा सके और बाद में मिनिस्ट्री ऑफ हेल्थ को दी जा सके। वैसे डीजीएचएस सर से मैं इस बात की रिक्वेस्ट कर चुकी हूँ कि वो इस पे थोड़ा सा दिमाग संज्ञान लगा के इस पे काम करें, जिससे अब जो महिलाएं हैं जो सफर करती हैं उनकी सफरिंग कम हो सके, बहुत हद तक हम लोग कर सके। तो वो इन्हीं सब चीजों को, मतलब ये आज बहुत ही अच्छे सेशन से, बड़ा बहुत अच्छा लगा सुन के। तकलीफें बहुत हुई, क्योंकि तकलीफ मतलब इतनी ज्यादा तकलीफों से लोग निकलते हैं जिनका समय सोचना भी मतलब हमारे लिए बहुत बड़ी बात हो जाती है। इतनी तकलीफों से वो निकलते हैं, हम सुन के ही घबरा जाते हैं, तो वो तो पता नहीं किस तकलीफों से। लेकिन इन्हीं सब शब्दों से बस एक ही बात कहूंगी कि बहुत अच्छे सेशंस थे, और ऐसे सेशंस होते रहने चाहिए जहाँ हमको भी सीखने का मौका मिलता है। थैंक यू सो मच।
Thank you, Vinita ji. Thank you, everybody. Bye bye.
थैंक यू सो मच विनीता जी, सभी का बहुत बहुत धन्यवाद। थैंक यू सो मच।